Hello, and thank you so much for joining us today. My name is Dr. Veronica Ajewale. I am the Director for the Community Engagement Core here at Texas Southern University. We want to say a big thank you for joining us for today's program. We are sure that you have had a lot of great information that is going to help us together as a community in addressing health disparity. Please feel free to share your comments with us, complete our survey, and most importantly, follow us on our social media pages. Our social media handle is CECTX Southern U. Again, we want to say a big thank you for joining us today, and we hope that you continue to connect with us. Thank you.
Good morning, good morning, good morning, ladies and gentlemen. Welcome, welcome. Dear all community members, speakers, panelists, vendors, health workers, volunteers, on behalf of the Community Engagement Corps of Center of Biomedical and Minority Health Research Program, I want to welcome you joining in person and also online. Welcome, everyone. My name is Dr. Ivy Poon. I am a professor in pharmacy practice, and it is my privilege and honor to serve as the Associate Director for the Community Engagement Corps. So I'm going to start off with the first couple of slides. Then we have a lot of events being scheduled. So our schedule of events goes from 11 in the morning all the way to around 2. We have a pack full of events, starting with the guest speaker, and then we'll have a panelist discussion. We will also have TSU debate team and talk about the T-HEAL program. And then we are going to launch the MH, the Maternal Health Rich program that we have here at TSU. And then we will have a closing remarks. Then at the end, around 1, we will have grab our lunch. And we have so many vendors out there. If you, when you're registering, you might have noticed. So we will give you a chance to visit the vendors, collaborate with faculty, and, meet new friends, and have a good time. So today's event will not be possible without the support of our vendors. So we thank you, our vendors, and also our sponsor for today's events. All right, so now I have a couple of housekeeping items that I want to go through. The first thing is during the presentation, so in a few minutes, we'll have a keynote presentation. During the presentation, if you have any questions, we will have a Q&A, question and answer time. So there are microphones on each side of this auditorium where you can, during Q&A time, you can come up and ask your questions. If you are joining online, if you have any questions, you can type your questions in the Q&A box, and we'll answer your questions accordingly. Now, also, we want to hear your feedback. So at the end of the presentation, we will pass out surveys. If you're joining in person, we'll pass out physical surveys, and we would like to collect those surveys at the end of the presentation. As you exit the room after the program, then we'll have a helper by the entrance to collect all the surveys. If you're joining online, then you need to click on the link where you will complete the survey through the link in the link tree, and then complete the survey. If you are CHW, community health workers, make sure that you complete the CHW survey so that you can get the 2 credit hours of CHW credits. So we will be streaming live on YouTube and Facebook, right? So you can share this event with your family members and friends. You can also hashtag us, TSU CEC MCH. The MCH stands for Maternal Child Health, which is the focus of today. All right. So now it is my honor to present the prayer, the person who will help us with the prayer. First Lady Janice came from Fallbrook Church, and she enjoys serving alongside with her pastor husband at Fallbrook in Houston, and together they have witnessed God grow Fallbrook from 5 families to over 10,000 members. Wow. and she served as ministry leader, a Bible teacher, and conference speaker to women. She has mentored and counseled hundreds of women in various life stages and developed programs encouraging their success. Her passion leads women to ignite with hope through a deeper relationship with God. First Lady Janice received a bachelor degree from UH Downtown, a master's degree in professional writing from Liberty University, and working towards the PhD in education in leadership at Tavika Nazarene University. So let's welcome First Lady Janice.
Thank you. Thank you. Thank you for inviting me. Let's bow in prayer. Heavenly Father, we come before you today in humility and faith. We thank you for all you have given us and the many blessings in our lives. Thank you for every seat that has been filled here today and the seats that will be filled, Father. Those who are watching online, thank you. For each mind and heart that feels the presence of this room, we thank you. Only you truly know what we are setting out to accomplish today. Bless this gathering of community leaders, speakers, and presenters with unity, hope, and vision, and may your vision fill our lives as we endeavor to advance health equity in our community. Grant us the empathy to see beyond the service and the surface and the compassion to connect deeply with those around us and beyond. Help us to gain many benefits from being here together. But most of all, may we seek to glorify your name and your name only. In all we ask, this is in Jesus' name we pray. Amen.
Thank you. Thank you so much. So next, I would like to introduce Dr. Michelle Penn Marshall. Dr. Penn Marshall is the inaugural Vice President of Research and Innovation at Texas Southern University. She has served as the co-PI for Maximizing Access to Research Career and Undergraduate Research Training Initiative for Student Enhancement, URISE, both designate to expand the number of underrepresented minorities in STEM who earn the PhD or MD PhD. Dr. Penn Marshall received her BA and MS in biology with a concentration in environmental science from Hampton University, and she received her PhD in community nutrition from the Department of Human Nutrition, Food, Exercise at Virginia Tech. So let's welcome Dr. Penn Marshall to give us the welcome address. Thank you.
Thank you very much, Dr. Poon. And good morning, everyone. Good morning, good morning. Thank you on behalf of Interim President Dr. Mary Sias and our Provost, Dr. Carl Goodman. We welcome you to Texas Southern University. I am so pleased always with the work that Dr. Veronica Ajawale, you start naming people, but she's leading this today, Dr. Veronica Ajawale does in the community. I welcome our vendors, our community members, our ministers, and everyone who realizes how important this topic is. I could stand before you and tout statistics. You're going to hear them today, and they are alarming and they have not changed. And yet we sit 2.5, 3 miles from the largest medical centers in the world. So the mere fact that you've recognized and have dedicated your time, that faculty and staff members and researchers are here today in order to change what we are reading and what we see, is going to make the difference. We must be educated. Our physicians who are here today also are going to educate their peers to listen to us as women when we speak, as women of color, when we say, no, that doesn't feel right. No, I really think I'm having this problem. And we have noticed it has nothing to do with your education, with the amount of money that you may earn. Beyonce has experienced it. Serena has experienced it. So it has nothing to do with that. It is our voice. So I am thankful that we started with a prayer, because it's going to take prayer. It's going to take physicians. It's going to take community leaders. It's going to take the next group of students that we are raising up right now to make a difference. And it's going to take us saying, no, this is not going to continue. So it's critical. It's critical. So I am very grateful for your vision. Where did Dr. Poon go? She moved, for Dr. Poon's work. And there are other colleagues. There's several colleagues. Dr. Olalaye always has a vision for research and solving the world's problems. And I'm honored to work with her. So again, welcome, welcome, welcome. And let's not leave here today without making a decision to do something about it, to teach someone what we've learned, and to continue to take this up as a banner. Thank you very much for your time, and thank you for this program.
All right. So,
I forgot to say two things. We want to invite you to I was very passionate about what I was saying and forgot what I was supposed to invite you to. Research and Innovation Week is March 18th through 22nd on Texas Southern University's campus. We're focusing on innovation, entrepreneurship, pitch competitions. We have got to get into the research and development world. We have to have patents. We have to make money for our ideas as people of color. The other thing I want to share, I was supposed to speak about the institution's commitment to maternal and child health. We're committed by our presence. We're committed by providing space and utilization, and also because of Ms. Zuri Dale, wave Ms. Dale, who is soon to be Dr. Zuri Dale. Our inaugural research magazine under this team is going to feature maternal and child health. So we look forward to you providing your input by February 15th, and Dr. Ajawale will receive information that she will be able to disseminate. Thank you very much.
thank you. Awesome. This is so exciting. I am excited. I don't know about if you're excited too, but this is such an exciting journey. So,
Thank you. Beautiful. Thank you again, everyone. Please help me to appreciate VP Penn Marshall. Thank you, VP. We appreciate your visionary leadership, your support, and your consistency in guiding us as we go through this all. Again, good morning, everybody. It is such a pleasure to be here with you all today. Thank you for making time to join us, both online and in person, for this really important discussion and conversation. My name is Veronica Ajewole, and I am a clinical pharmacist by training, a graduate of Texas Southern University. So yeah, a proud Tiger product of this same institution. And I am an associate professor of pharmacy practice. I do have the privilege to be the founding director of the community engagement core that we have here at TSU. I am also the principal investigator and the director for the Breast Cancer Screening and Prevention Center. So I welcome you. Thank you very much for joining us this morning. Over the next few minutes, I'm going to talk briefly about the Center for Biomedical and Minority Health Research and what exactly do we do here at the Community Engagement Core. As we can see on the slide, the Center for Biomedical and Minority Health Research is funded by NIH, $8.6 million award that we had the privilege of receiving in 2020 under the leadership of my amazing mentor, Dr. Monica Olalaye, who is seated right there. You would have the privilege of hearing from her later during this presentation, alongside co-PIs Dr. Jay as well as Dr. Liang. Under the CBMHR, we have three major pillars, one of them being the Community Engagement Core that I have the privilege of leading, as well as the Research Investigator Core, which is led by Dr. Gao, and then the Investigator Development Core that is led by Dr. Poon. Dr. Poon was the person that helped us in opening today's session. So all being said, the Center for Biomedical and Minority Health Research is really positioned here at TSU to help us address health disparity with advanced biomedical innovation and community engagement. And truth be told, we can't do any of this without each of you that are in this room this morning, without those that are joining us online, and without the support of all our stakeholders and collaborators. I talked briefly now about the community engagement core itself. It looks like the slide is faded off. My apologies on that. But the community engagement core itself has 3 major goals. The first goal is for us to identify and address the health needs of the community. We can't do that without you. So that is why we are always in the community conducting surveys, focus groups, listening to what you guys are telling us so that way we are better positioned to be able to address the needs of the community. In addition to that, our second goal is to increase and advance clinical research awareness and participation. That is very important. Later on today, I would have the opportunity to tell us about the Clinical Research and Engagement Conference that we would have in April, and I hope you guys can join us. That is going to be another incredible opportunity for everyone to learn about clinical research and how you guys can, collaborate with us in implementing those plans. The third thing that we do in Community Engagement Core is for us to be able to disseminate the findings of research. As faculty, as researchers, as professors, we are very comfortable attending scientific conferences. But those scientific conferences means nothing to the community members that are seated in this audience this morning. It doesn't mean anything to the audience that are online. So we need to be able to create an innovative way to disseminate the findings of research to lay community members. And that is one of the things that we do in the Community Engagement Core. You guys will probably wonder, hey, is Veronica doing this all by herself? Absolutely not. It takes a village of individuals, faculty, and staff members all across the university supporting us as we implement the plan for this program. I would like to appreciate and acknowledge all our full-time staff members, Virgil, Elkins, Cassie, Sneha. Some of them are not on this slide, but we have Xiomara and Crystal, we have Dolores, Nakisa, and many more new staff members that we will be hiring alongside the faculty and staff that are all across the campus helping us as we implement the plan for this program. I will be remiss if I don't pause to appreciate my husband. Please help me to appreciate my man of God, my mentor, my support. His fingerprint is in all the grants and all the works that we do. He helps me and supports me. We've been married. It's going to be 12 years this summer, and I am so blessed to be married to you. Thank you, babe, for your love and your support. I appreciate it. Thank you. Then again, cycling back on some of the great works that we do at the Community Engagement Core, we work closely with FQHCs, community-based organizations, churches, religious organizations. Hey, we also engage our elected officials, right? Our commissioners, precinct leaders, they are in rooms that we are not in, so that way they can continue to help us advocate for what is important to the community. We listen, we conduct surveys, focus groups, we conduct community engagement studios. Those are the way and dynamics that we implement to be able to identify the topics and what is important to the community and implementing or deciding the topics that we focus on. We are an academic institution, so we provide continuing education to CHWs. This program is also one of those that is available as a community health worker continuing education. So till date, I said earlier that we've been funded since 2020. We've had a lot of success, but I just want to highlight some of those, if you look at the numbers of some of the things that we've been able to do. We've hosted several conferences, hosted several seminars, and we've been able to collect over 650 surveys and having an attendance of over 2,000 individuals joining us for some of our diverse programs, both in person and online. Then I'm going to switch gears a little bit here to talk about the Breast Cancer Screening and Prevention Center. Breast Cancer Screening Prevention Center is funded by CPRIT, which is a Cancer Prevention Research Institute of Texas. It is a $1 million award, and I have the privilege of being the principal investigator and program director on that. You see the faces of these amazing people. These are our, 3 full-time staff that we have working diligently as we implement. And as a matter of fact, as we speak right now, we have our mobile unit on Tiger Walk where we are providing mammogram to 27 women. First Lady Janice will be in Fallbrook Church in March. Yes, we will be at Fallbrook Church in March. So these are all the works that we do as we, continue to advance health equity in the community. Again, if you look at our breast cancer program by the numbers, we are really excited that between March 2022 and November 2023, we've provided education to almost 3,000 individuals. We have provided navigation to almost 3,000 individuals and provided no-cost mammogram to almost 900 women here in the city of Houston and its surrounding environment. Please help me to applaud the effort of our staff members that are very dedicated in implementing this plan. I'm going to go over some of the additional works that we have the privilege to implement here at Texas Southern University. AFLAC reached out to us a few months ago and awarded us $0.2 million in advancing the works that we do here on TSU campus. That has allowed us to be able to create fellowship program for both undergrad as well as high school students. We are doing a lot of great work in the community with the funding that we receive from AFLAC. This is another really prime opportunity that I'm really excited about. When we talk about clinical trial participation, it is very key and important that we partner with the community so that we can advance and increase the number of individuals, minority individuals that are in clinical trials. But we cannot do that without resources and with the money. So guess what? God made a way, and we did receive funding that we will be implementing in a few weeks to implement the very first clinical trial site here at Texas Southern University. And this is community-based. We are going to have representation all across the board to ensure that we can successfully implement this program. The other one I want to highlight is the P20 grant that we received from NCI. This is under the National Cancer Institute, where we are positioned to train 80 minority students from Texas Southern University that would help us to diversify the workforce. When you're looking at people in oncology nurses, oncology pharmacists, oncology physicians, and things of that nature. We recently hired on the Cases app. She is our project manager under this grant. And the exciting thing is that this grant is the only one funded in the entire United States this year. And this is the first of its kind here on Texas Southern University campus. So we are really excited about that. Another big project, a 45-foot mobile unit is going to be on TSU campus about 4 months from now. I hope you guys are excited the same way that I am. On these mobile units, we would have a mammogram suite. We would have a room that will be ready for preventive care. We can give, administer immunization, screening services we'll be able to provide, and also be able to provide some community engagement work on the mobile unit. So I have said a lot, and I'm obviously above my time there, but all the works that we do at Texas Southern University can really be summarized to say that we are implementing ways to transformatively, innovatively advance health equity. So we are here creating pipelines, creating opportunities for grants, for donation, for us to be able to engage with community members, to listen, so that all that we do, we are able to successfully advance health equity. Once again, I want to say thank you to all of you for joining us this morning. And if you ask yourself, why are you here? The weather today is beautiful. You could be outside walking your dog or doing anything else that you like to do. But let's just really think back and say, why are we here this morning? Not only why are we here this morning, why did we choose this topic of maternal and child health? The numbers tells us to do that. Our own personal experiences tells us to do that. And when we look at the statistics, it is worsening for African American population. So we need to really think and say, we are here this morning to listen to the experts, to be able to have a collaborative dialogue. And hopefully, my hope, honestly, is that we are raising awareness, we are going to be empowered to advocate, and most importantly, we can take an action. We are going to all do something differently after today's program to help us together in advancing health equity. So it is going to be my pleasure this morning to bring up stage our guest speaker, Dr. Erica Giwa. Dr. Erica Giwa is a Houston native who has practiced obstetrics and gynecology throughout the city since 2010. After attending the Michael E. DeBakey High School for Health Professions, she graduated from the University of Houston with a BS in biology. Then she received a medical degree from the University of Texas Southwestern Medical Center. She returned to Houston to complete her residency training in LBJ Hospital and then began a career in private practice near the medical center. Her passion for promoting health equity and providing quality health care to underserved women has led her to transition to a patient care medical home practice designed to provide quality, integrated care to women and families. Our most recent posting is at Legacy Community Health, where she currently serves as the medical director of obstetrics and gynecology. Please join me as I bring up stage Dr. Giwa. Thank you for joining us today. It's okay.
Good morning, and thank you so much, Dr. Adewale, for inviting me. I actually had the pleasure of meeting Dr. Adewale for the first time and her team. Was it about 6 weeks ago or 8 weeks ago? And we realized that we had a connection through my husband that was participating in her training. So the world is so small. When I saw all of the things that you just saw today at our meeting, I was like, oh, this is a team I have to stay connected with. So when they reached out to me to present today, I was like, let me move some things around, because when you all start doing all your projects, I don't want you to forget legacy. So it is a pleasure to speak to you all today. We have been inundated with information about maternal health. And I'm glad that Dr. Penn mentioned sometimes we are receiving information as professionals, and we don't know how it's received as at the community level. So I feel like I've been receiving information upon information upon information about maternal health, but I want to start today. I'm not going to start talking. I want to hear what you all think. So first question, I don't have I thought my little QR code was going to come up, but it's not. So this was supposed to be a word cloud, but y'all are going to have to shout it out to me today. Y'all have to participate. So when you hear the phrase maternal mortality, what comes to mind? Like, what are you thinking? Just shout out some things. Death, Black people, mothers, travesty, disparities. These are good. Houston. Racism. That's good. Motherless children. This is getting deep. So, okay. Now, when you think about maternal morbidity, does something different come to your mind? Like, what are you thinking about this? Because these are two different terms, and I usually don't stop. I usually don't slow down to differentiate between these two. But as we're talking about solutions, I think it's really important. So what comes to your mind when you think about morbidity? Is it something different? Equity. That's a good one. Food deserts. That's a good one, too. Anything else? Chronic diseases. Health education. That's awesome. So I want to just define both of these for you. So morbidity is any health condition contributed to or aggravated by pregnancy and childbirth that has negative outcomes to the person's well-being. So this is some of the things that you named, and I'm really glad that you all said some of the things you did, like food desert, chronic illnesses, because these are big things that even when I trained, things like food deserts and social determinants of health, I didn't learn that in medical school. I'm learning that now. So hypertension, diabetes, obesity, these are things that could be pre-existing or exist during pregnancy that cause complications. So mortality is the death of a person during pregnancy or within 1 year of pregnancy related to that complication. And so that's something I also did not learn in medical school. I didn't know that it was up to 1 year. So we're going to talk a little bit more about that as we go through the presentation as well. So the stats, and many of us have heard the stats, but I'm just going to review them today so we kind of know what we're working with and understand the scope of the problem. So these are the trends in pregnancy-related mortality. So this is mortality in the United States from 1987 to 2019. And so you can see there's a steady trend upward in the maternal death. And, you know, as a health professional, this was shocking to me. Because we'll talk about Texas data, but like was mentioned earlier, we live in Houston, Texas. This is the largest medical center in the world. I was shocked to learn that this was happening in our communities. So this is actually provisional data from the CDC, and they're going to finalize these numbers, but I wanted to show this today because over the last 5 years, we have been doing a lot of work, particularly in Harris County, Texas, to reduce these numbers. So this is from January 2019 to 2023, and I hope that once they finalize these numbers, these are true. But you can see there was an increase here, and we're kind of coming back down. But even in coming back down, we're still high, but we're moving in the right direction. So I'm hoping that a lot of the interventions that we're making, we're seeing impact from those. Yep. So this is data. Here we go. This is U.S. data from 2018 to 2021. This is stratified by race. So when we look at maternal deaths, you can see the total, then you see non-Hispanic Black, non-Hispanic White, and Hispanic. And we know that the deaths are concentrated in the Black community. Black women are 3 to 4 times more likely to experience maternal death, and this is not related to socioeconomic status. And we'll talk a little bit more about that. This is stratified by race. And so I talk about this a lot, but I don't always highlight, stratified by age. And so age is also important. We can see the higher values in moms 40 and over. And this is particularly important because I think that as communities, moms are having babies later, they're pursuing their careers first. And so we're seeing a lot of morbidity and mortality in this population as well. So this is Texas. This is us. This is why we're here. So you can see the bottom line is, in blue is the United States. Texas is much higher than the United States. And so one of the things, I don't know if you all know, 50% of the babies in Harris County are born to moms who have Medicaid. And this is why, particularly why this has become one of my passions, and I really love serving in this population because these women are underserved. They're not receiving care before they're pregnant. They have all these comorbidities that are not managed prior to pregnancy. So hypertension, diabetes, obesity, depression, anxiety, those things are existing without treatment because these moms don't have care. And so then you enter into pregnancy and you have pregnancy on top of those things, which increases the morbidity and mortality for this population. So this is Harris County, this is us, and I put my little two, these were supposed to pop up, but I put my little 2 stars so you can see kind of where I practice at Legacy Community Health and where TSU is. I'm not the best with maps, so I think that's where it is. But look, you can kind of look and see where your community falls on this map, and you can see where the hot spots are. So the hottest spots are definitely in our rural areas, which is related to access. But then still, as you go into the loop, you can still see that we're experiencing a good amount of maternal mortality in these communities. And I also did not want to forget infant mortality. This is maternal and child health. So these are very closely linked. If mom delivers early, that's a baby who's preterm, going to the NICU, increased risk for morbidity and mortality. Reasons that moms deliver early: hypertension, diabetes. These are things that potentially are uncontrolled during pregnancy. So it impacts the baby as well. But I'm happy to say that over the last few years, we can see this number kind of going down. We're kind of plateauing right here, but moving in the right direction, so not increasing. So I want you all to know that maternal mortality does not just happen. And that's why I kind of slowed down at the beginning to talk about morbidity, because morbidity is very important. So for every maternal death, there are about 100 cases of maternal morbidity. So, you know, I see patients, this is just like weight gain. You know, I see patients every day and they're like, I gained 30 pounds last year. You didn't just wake up with the 30 pounds. Something happened, right? Y'all were going Popeyes, y'all were eating some Doritos. Y'all did something to gain that 30 pounds, right? And so I'm not saying that maternal mortality is anyone's fault, but I'm saying that there are modifiable risk factors that we need to pay attention to before we get to the top of the pyramid. So I love this pyramid, because it kind of illustrates where we are. So at the bottom is uncomplicated deliveries. And if you talk to any obstetrician, they will say they don't do any of these. They say all of them are complicated. That's how it seems. That's not really true though. So as you go up the pyramid, you see there's maternal morbidity. So these are things that we talked about before: obesity, hypertension, diabetes, postpartum hemorrhage. And then this severe maternal morbidity category is where we really want to focus. So ICU admission after delivery. So these are ladies who had, sometimes you have an embolus, if y'all have ever heard of anybody having an amniotic fluid embolus, or you have clots, like Serena Williams had a clot after she delivered. These ladies will go to the ICU. If you have heart attack or stroke following delivery, blood transfusion greater than 4 units of blood or 4 bags of blood, or a cesarean hysterectomy. So cesarean hysterectomy is if we deliver the baby and you're bleeding so much so that we have to remove the uterus. So that's going to be an ICU admission. So anyone who falls into this category has an increased risk of maternal death. But again, there are 100 of these for every 1 maternal death. So as the medical community, what we're really trying to isolate is what is putting people in this category, so we can not get to the top of the pyramid. So this was also supposed to be an interactive thing, but y'all shout out to me. So what do you all think is the leading cause of maternal death? Bias. Medical racism, lack of education, lack of health care, depression. Oh my, okay, here we go. There was another slide in there, but it's actually cardiac disease. And so this was shocking to me too. And I went to medical school and training for a long time, and I did not know this. So the number 1 cause is cardiac disease. And so that's important for us to know as we're talking about modifiable risk factors and what we're going to do to target this. So cardiac disease, followed by drug overdose, hypertension, and you can see even homicide and suicide are listed on here. And I put both of those kind of in the behavioral health category. So when we're talking about cardiac disease, what happens, the physiology of the body changes tremendously during pregnancy. And what happens a lot of times to the heart is that it becomes dilated. It's something called dilated cardiomyopathy. But when the heart gets too big, it doesn't pump as well. So if you're not pumping as well, you don't get the circulation to the rest of your body. So this is actually the number 1 cause. And I'm going to come back to this as we talk to solutions, because it's really important as a community to know that. Okay, so working towards solutions. there's no easy answer to this. This is multifactorial. And you all have shouted out so many things that I am actually surprised that y'all shouted out, and I'm glad that you all did. But we're going to talk about some of the things. And so I've listed kind of all the impacts to maternal health, and we'll go through each of them one by one. So earlier I mentioned that 50% of babies in Harris County are born to moms who have Medicaid. It is very difficult for moms to get on Medicaid. I care for almost 100% Medicaid patients, and I'll talk to moms who turn in an application. It takes sometimes 45 days for that application to get approved. So I'll tell you this stat too, 50% of pregnancies everywhere are unplanned. No matter whether you're married, unmarried, insurance, uninsurance, most of the pregnancies, 50% are not planned. So if you imagine, and you think about all the ladies in the room, or the dads in your room, think about when you found out you were having a pregnancy. Sometimes you're already well into the pregnancy. You're already well into the first trimester. So if you're 8 weeks pregnant or 10 weeks pregnant when you have a positive test, then you apply for Medicaid, and that takes another 45 days. That's a long time. Then you have to find a provider on top of that. So this is delaying care for a lot of ladies in Texas. But what I am happy to announce, I had to include this slide on this screen, and I'm looking at Kay. I'm sure Kay is super happy about this, Kay Matthews. The feds approved 12 months of Medicaid coverage for moms after delivery. So it takes a long time to get on, but once you're on, you have that coverage for 12 months. And we have been working on this. The community has been working for a long time, going to the state, testifying. So this is a huge win for Texas. So what this means is that you remember the number one cause is cardiac disease. So when those moms are diagnosed with a cardiomyopathy, the recommendation is to have an echocardiogram at 6 months and 12 months. Previously, Medicaid termed at 8 weeks. So there's no way that those women could get follow-up, and now they can. So this is amazing. And not only that, but all the other conditions, the hypertension, diabetes that we spend so much time doing pregnancy, teeing up, getting them on meds, these ladies can remain in treatment for at least 12 months. So this is amazing. So implicit bias, I could spend an entire hour talking about this, but I only got 20 minutes. So this is has a huge impact on medical care. And so as I thought about a concise way to talk about this, I think a lot of times I'll talk about myself, when I think about implicit bias, I'm thinking about what everybody else is doing. Like everybody else is looking at me and saying she's gonna think this way or she's gonna do this way because she's a Black person. And so what I wanna challenge you guys today to do is look internally. Because when I think about implicit bias, sometimes I get overwhelmed because I'm like, how can I change what you're thinking? I can't. Like, I don't have any control over what anyone else does, but I have control over myself. And so what I had to do was sit down and say, hey, girl, me, what thoughts are you having that are biased? And we all have them. And I think sometimes in the Black community, we think that everybody else has them against us, but that is not true. It's partially true, but you have some as well. So as a provider, I had to sit down and say, okay, what are the things that I am thinking that can impact the care of my patients? And so I listed some of them here. And these are not all my thoughts. I'm not going to claim all these, okay? I'm just these are some things that I hear on L&D that are biases that impact care. So the first one is Black women do not breastfeed. Hispanic women do not want their babies circumcised. These are real thoughts. Somebody's thinking this thought right now. Hispanic women have a lot of children and they labor quickly. Most of the Medicaid population is African American. Medicaid patients are not compliant. Medicaid patients are uneducated and poor. White patients are compliant and engaged in their health. So these things seem pretty benign, right? I promise you, I hear one of these things on a daily basis. But if I think that, right, if I think that Hispanic women labor, they have a lot of children and they labor quickly, then when I'm seeing her as a doctor, maybe I don't talk to her about birth control because I'm like, oh, she only got one kid, she's gonna have 5 more. Or if I say she labors quickly, maybe I'm not gonna go to her room as quickly when she comes to the labor unit because, or, you know, I'm saying, oh, she doesn't need my help. I know she's going to have babies. It really impacts what you're doing. And so I challenge you all, whatever your field is, particularly people in healthcare, to think about how you are thinking about your patients and how is that going to impact what you're able to do for that patient. And also, when we're out with our friends and you hear these things come out, challenge your friends and say, hey, you don't know that person. So the person that you experienced that was that race before may have handled a situation like that, but you don't know this person that you're talking to right now. So you need to take time to get to know who that is. So I started my mom actually recommended this book to me last week. And so I started listening to it, and I hurried up and added this slide in here because I really wanted, as we're talking about how to address bias and what we can do individually, this book really helped me to bring this point home. So I think that we know that it is difficult being Black in America. That is understandable. We know that. It is difficult being the person receiving the bias, okay? And one of the things that we know is that if your mental health is impacted, it also impacts your physical health. And so I want to give y'all an illustration. It's not going to seem related in the beginning, but it is. So just bear with me. So my son was in swim class. And one day his class got canceled. And so I talked to one of the other parents and I said, hey, do you know what happened? Why did they cancel the class? And she said one of the instructors was in the pool and that the instructor either had a seizure or wasn't feeling well. And so they thought the instructor almost drowned. So they had to rescue the instructor and call the ambulance, and they canceled all the classes for the rest of the day. So this happened around 3 o'clock. My son's class is at 6. And so I'm going to tell you my first thought. And I don't want y'all to think I'm a terrible person. I'm not. So I thought, well, why did they cancel all the rest of the classes? Are the rest of the instructors okay? And I'm like, can the rest of the instructors do the classes? I didn't understand. And so then I sat back for a moment. You know, if you imagine being there and witnessing that, that's traumatic for everyone, right? And so they had to watch their colleague go under. They had to call the ambulance, get all the other kids out. And so that's traumatic, but that was not my first thought. And I'll tell you why it's not my first thought, because in medicine, we don't train like that. And so medicine is kind of hardcore. It's like you keep going. You don't deal with your traumas. You have bad patient outcomes. I've seen babies die. You've seen moms die. You just keep going. You just keep going. And so in my mind, I'm like, you just keep going. Like, you don't get sick. If you're not in the ICU, come to work. Put your clothes on, And so, but that's not normal. And so as I think about this related to being Black in America, we have internalized a lot of traumas that are not normal. So it is not normal for somebody to walk around behind you at the store thinking that you're going to take something. It is not normal for us to work twice as hard with minimal resources. It is not normal for us to sit at our tables talking to our sons about what to do when they get pulled over so they don't die. That's not normal. And those are stressors that we internalize and we carry, and it impacts our mental health, it impacts our physical health. And so what I love about this book is that she acknowledges that. And she talks about a protection factor. So when you put on sunscreen, they have the SPF. And so you have different levels of SPF. She talks about a protection factor for your mental health. So, and she makes it okay for us not to carry everything. You don't have to carry everything. You don't have to be strong all the time. So you can say, okay, if your PF is 10, you're okay. If your PF is 4, you're not. And so if you notice day after day after day, you're at a PF of 2 or 4, you need to check in with somebody. You need to get some help. And it is okay to do that. And it is okay for our moms to do that. It is okay for us as a community to do that. And we need to recognize what we're carrying as a community. So the next thing is lack of postpartum follow-up. That impacts prenatal care. So I had to, when I started working on maternal mortality and all these committees, I really had to challenge myself to recognize that the postpartum period is not like, okay, you're done, because in your mind, you're like, okay, she had the baby, you're done. But most of the postpartum deaths are occurring after delivery. More than 50% are occurring after delivery. I went a little too fast. So it is really important, if you are a mom, you know a mom, you're around someone who's had a baby, encourage that person to seek care in the postpartum period. This is when we're identifying that postpartum depression, that preeclampsia that may have developed after delivery. So it is super, super important. And Dr. Adewale talked about breast cancer screening. I have diagnosed breast cancer during pregnancy and immediately following pregnancy. So I know a lot of moms think that it's not safe to get mammograms during pregnancy. You can, particularly if you have had an abnormal breast exam, you should get that evaluated, and it can be done during pregnancy and immediately after pregnancy. So do not delay your screening. Moms who are diagnosed in pregnancy or immediately after pregnancy typically have a poorer prognosis. Those ladies are usually younger. They have the estrogen circulation in their body from pregnancy. So these women are people who we absolutely want to find early. Another factor is mistrust of safety net providers. So a safety net provider is somebody like me. So I practice at Legacy Community Health. I spend all of my time caring for underserved or uninsured patients. And so we spend a lot of time talking about how are we going to make sure moms get transportation if they don't have it? How are we going to care for moms if they don't already have insurance? This is a part of our day-to-day life. And so what I know happens is that there's a stigma related to going to Medicaid clinics. But really, these clinics are set up for patients who do not have resources. So as a community, we're all talking to people who are pregnant, our grandchildren, our nieces, nephews, or not nephews, our nieces. That's what I really want the community to understand. So we might not have the chandelier hanging in the lobby, but we are going to have somebody who is going to find what they need. And so that is the beauty of the safety net environment, because that is what we do. That is our specialty. So when you have patients or family members who have not received care for a long time, and they say, I don't want to go to X place, or I don't want to go to Y place. For whatever reason, really look to see what resources that place has and who will better serve your family member or your patients. And we're almost at getting to the end of these risk factors or the contributors. But one of the things that contributes is disconnected reproductive care. And so disconnected in many reasons. A lot of times patients are seeing their primary care doctor, then they get pregnant, and they stop seeing the primary care doctor and go right to the OB, but there's no connection between those two. And a lot of medical terms are difficult to remember, so you don't remember that you had cardiomyopathy. So then when I ask you what medical problems that you have, some people say none. Or they think that, because I had the hypertension and I'm taking the medicine as normal, so now I don't have hypertension anymore. And so that's a disconnection. There's another disconnect sometimes with medical providers, because now we realize that only a small portion of medical care is what is actually happening in the room with me, about 20%. A lot of the other factors that impact the care of patients is all these other things: health factors, physical environment, socioeconomic factors. So that's why I was so happy to hear people yell out food deserts and things like that, because that really impacts your care. So as a physician, I know that if I say, okay, you have diabetes and I want you to be on this diet, if you're in a food desert, you're not going to be able to get that food that I'm telling you to get. So these are all very, very important. And then lastly, many times we prioritize the infant's health over mom's. And it's just natural. We love babies. We love to see babies. We love to hold the babies. And then we kind of, as a community, think mom's going to be okay. We don't check on her. And a lot of times mom is not okay. A lot of moms are suffering from postpartum depression. A lot of moms are just having difficulty raising the baby. I had difficulty after having my kid. I was like, have people been doing this? And so just as a community, make it a point to check on mom. And don't say, are you okay? Ask, can I help you with something? So can I bring you some food? Can I watch the baby for 10 minutes while you take a shower? So be specific, because if you're general, then that's one more thing she has to think of how you can help her. And it's stressful. We all know when we have babies, it's stressful. So these are all things I think that some of the things are huge. And one of the huge things that we already accomplished is getting care for 12 months. So as a community, when we're talking to our family members, make sure they're going to care. Make sure we're paying attention to mom and not just baby. Make sure we're checking our own bias and make sure we're checking our own mental health. And these are things that we can do individually to drive these numbers down. And that is all I have. Oh, I think it's questions.
We have time for 2 quick questions, if there is any questions in the audience.
I don't have a question, but I have a comment. Excellent presentation.
Thank you.
Great information, and the delivery was superb.
Thank you. All right.
Oh, wrong way. Okay, back again to our Q&A survey and social media. You can always scan the QR code to access the survey, as well as our assistants will be handing out a physical survey form so that you can fill out while we're watching these presentations. That way we can have some knowledge of how you experience this presentation, this event, and we want your feedback so we can improve for each event coming forward. Oop, wrong button. So we will now be moving into the Maternal Child Health Lived Experience panel discussion. We'll have our moderator as Pastor Sun Akeredolo. I hope I said that right. She's remarkable and resilient and inspiring woman of God. She has overcome major setbacks in life by the grace of God, has emerged stronger, and is thriving in all areas. She has a God-given mandate to help women arise, recover, and reign in her passion to inspire hope in women who are dealing with loss, infertility, abuse, and other challenges. She's a medical professional who carries this same passion in her work. She seeks opportunity to instill hope, encouragement, and even the patients she cares for. And she serves in her church in several capacities and is sold out in propagating the gospel of Jesus Christ. And she lives in the greater Houston area with her young children, Ivana and Isaac. So, Pastor Suna Keredolo. You can take a chair. Our next is the panelist, Dr. Aminat Teriba. She currently works as a population health clinical pharmacist at Village Medical, where she collaborates with physicians to provide professional services to improve health outcomes and patient experience. She has earned her BS in microbiology and has obtained her Doctor of Pharmacy from Texas Southern University, and she is residency trained and has obtained board certification in pharmacotherapy. And her interests lie in the utilization of public and population health to improve clinical and health outcomes and pursuing training in PHMDA. So, Dr. Teriba. Our next panelist was just up here, Dr. Erica Giwa. As you've already heard, she's a Houston native who practiced obstetrics and gynecology in the city throughout 2010. She has earned her BS from the University of Houston in biology and her medical degree from UT Southwestern Medical Center, and completed her residency training at LBJ Hospital. And her most recent posting is at Legacy Community Health, where she currently serves as the medical director of obstetrics and gynecology. Our next panelist is Ms. Kay Matthews. As the founder of the Shades of Blue Project, Kay Matthews and her team are on a mission to uplift all birthing individuals with care, respect, and dignity that they deserve, no matter where their social status or birth outcomes are. They focus on birthing experience, and this is how they bridge the gaps by acknowledging everyone's birth stories. Through education, advocacy, and support, they are dedicated to helping birthing individuals of color whose lives are impacted by racial disparities that amplify their birthing struggles. It is from her personal experience of infant loss and postpartum depression that she recognized a critical diversity gap in mental health resources and emotional support for Black and minority birthing individuals and their families, which is what we are working to dismantle through our work and advocacy. Ms. Kay Matthews. And our final panelist is Ms. Catrice Harris. She's encouraged to support women after birth of her own daughters. Catrice Harris has been helping families with childbirth education, labor and birth, postpartum, and lactation support since 1992. Her initial lactation training was through the University of Texas Health Science Center and the City of Houston WIC programs. She then became certified as a birth and postpartum doula. After observing many challenges faced by women, it seemed that the only next step was to pursue midwifery. Becoming a midwife has been a journey that constantly presents new opportunities for growth in many beautiful ways. Currently, with a solo home birth practice, Catrice also trains and mentors doulas through a grant-funded program seeking to provide birth support to underserved communities in Houston, Texas. Having supported over 365 families with the births of their babies as of 2023, she is truly grateful that this work has found her. Ms. Catrice Harris. And now we'll begin our panel discussion.
Hi, good morning, everyone. It's a pleasure for me to be here. I'm just honored to be here. Thank you, Dr. Ajewole, for inviting me. I think I was here 2 years ago for this, and I'm so passionate about this because I've had a lived experience of maternal child health, and a few times I've had close calls with, someone like a sister to me and my own sister. So it's great to be in the midst of people who are equally passionate about this cause, and I'm excited to be here to continue this conversation. So thank you, Ms. Matthews. Thank you, Dr. Giwa. Thank you, Dr. Teriba and Ms. Harris for being here today. So my first question is going to go to you, and I just want to remind our panelists we'll have 2 to 3 minutes per question so we can manage our time well, okay? And so, Ms. Matthews, what was your maternal and child health experience? If you can share that with us, please.
So, not for anyone to get sad. I feel like when you have a panel or a discussion around lived experience, the purpose of it is to listen, take that information back, and share it with the next person or to learn from it. So my maternal child health experience ended in infant loss. Unfortunately, I delivered my daughter stillborn full term. And so many things came along with that experience that I didn't know because there was no education given to me. It wasn't a part of the everyday conversations that folks were having. So I literally had to navigate that experience on my own. Which is why I always say we focus on birthing experiences versus outcomes, because that's very important. When you only focus on the outcome, and in reality, we think a live birth is the only thing that could happen. So when something adverse happens, you kind of push that to the side. So that was my experience that really propelled me into wanting this thing to be different, because I knew that it could. Anytime I have to ask why, I know things can be better. Anytime I ask you why, that's because I already know that there should be something else happening behind that. So my question became, why is it that I had to navigate for almost a year before anyone would understand what I was telling them about me? Not about somebody else, but simply about me. So that's been my, that's what brought me here. Let me say that. Luckily, gracefully, prayerfully, all those things, that it did not keep me there, because I see day to day how folks who have adverse outcomes, or even those who have living children, still go through things and don't know how to navigate it. So, yeah.
Thank you so much for sharing that. And I'm going to ask you the same question, Dr. Terry, about what was your maternal and child health experience?
Thank you so much for the question. So I'll echo what Ms. Matthews said. So my maternal and child health experience when I was in pharmacy school at Texas Southern University, I had a baby and I was sick during the pregnancy. I was this quiet student in class. I would not talk, but I was doing well. So that made Dr. Ajewale to notice me in class because I was doing well. So she knew me through that. And there was a time we were doing one of the presentations and I just went to her, please, can I sit? Then the next class, I was not myself. I was pregnant. The pregnancy was not showing, nobody knew. Then she called me. She said, what is wrong with you? And I didn't want to talk. Before the pregnancy, I had no chronic issues. But during the pregnancy, I was seriously sick and I had some issues. And no chronic conditions still, but I had a lot of issues. And Dr. Ajewale basically stood on my neck until I was supposed to tell her, like, I am pregnant. And she was like, are you receiving support? Do you have this? Do you have that? To the point that after I gave birth, I had to reach out to her via email. It was during summer break, like, I have given birth this. And she shared her experience, like, I was pregnant twice in pharmacy school. This is doable. Let me know if you have anything. So I received that support. To the professional part, I can remember when I was a pharmacy intern at one of the community pharmacy located in a Black community, and patients would come in to talk to the pharmacist, the most accessible healthcare worker in the community, to say, my doctor asked me to get the Tdap vaccine and I don't want to get it. And at a point, I had to go on the CDC website to read so much about the Tdap vaccine. Then I started counseling people under the supervision of my preceptor, like listening to their concerns, telling them everything is valid, and I would counsel them, display empathy, let them know this is for the safety of yourself and for your child. This is not about labeling, this is not about anything, but Dr. Giwa said it. Mortality is high among the Blacks. I worked in the Black community then, and I could say personally, 90% of those patients who pushed back, they were Black. And we all know as healthcare workers here what Tdap vaccine can do, the benefit and the indication. And it actually took a lot to convince people to get those vaccines. So those are my experiences.
Wow, thank you so much for sharing. Miss Matthews, you are a licensed midwife. I'm sorry. Oh, Matthews, I'm sorry. I got it backwards. Oh, Miss Harris, I'm so sorry. I was looking at the Miss Harris, I apologize for that. You're a licensed midwife, and for me, when I had my children, I went to standard for all of us to go to an OB-GYN like Dr. Giwa or go to a hospital setting to deliver. And over the course of the years, as I've kind of paid more attention to maternal child health, I wonder if there is a added benefit to having a midwife versus the standard delivery method where we're all brought up. So my question to you is, how is home birth and doula services, are they safe? And how does that impact pregnancy outcomes?
Well, the short answer is yes, they're safe. Women need prenatal care. Everything that Dr. Giwa talked about in her presentation is spot on necessary. A lot of the problems that we see can be taken care of ahead of time, and if a woman enters pregnancy healthy and without complications or risk factors, then a home birth is a good option. In the United States, and then trickling it down to Texas, fewer than 1% of women actually have their babies with midwives, but it is a good choice. It's not everyone's choice, and I wouldn't say that there's a better or worse regarding doctor or midwifery care. It really depends on what that family wants. If a woman has health issues such as high blood pressure or diabetes or other risk factors, then it's better that her care be with an OB-GYN, someone trained in medical care. Midwives provide care for women who are not ill. So we call our families clients rather than patients. And the numbers show that it is a safe alternative. Doula care is well, very safe. It's non-medical. If someone has a doula, the doula is there to provide support during the pregnancy and also in the early part of labor, and they can also stay on through the birth, and then there are postpartum doulas as well. I keep going back to Dr. Giwa's presentation because it was so great, but postpartum care provided by someone who's dedicated to just your recovery and well-being helps to improve the numbers for women and with regard to postpartum depression and things such as that.
Awesome. Thank you for sharing that. And just to clarify, I'm not saying that we forego OB-GYNs and go to midwives. It's important that I'm a primary care provider, I'm a physician assistant, so I understand the importance of having a medical home. So it's very important to have your OB-GYN, but in some cases, like Ms. Harris just mentioned, it may be better, or it may actually, not better is the word, but it may be safer for you. It's an option for you rather to have a midwife or doula deliver you. So I think you may have touched on this. My next question was going to be, are all women eligible for doula services? And are most of those, is it covered by most insurance?
All women are eligible in the sense that doula support is really just an additional person who is there emotionally for you, but they're not as tied in emotionally as perhaps a family member would be. I like to say that doulas support rather than rescue a woman from the experience. So anyone can have a doula. Doulas support the partner or the dad or the husband at the birth as well. As far as insurance coverage in the state of Texas, again, the short answer is no. There are some other services such as childbirth education, lactation support. If the doula is able to provide those services, then sometimes reimbursement can take place for those services. I know there are some Medicaid reforms in process right now that are hoping to change that so that Medicaid is approving of doula support and providing that. There are some grant-funded programs that will put doulas in those birth spaces. University of Houston Healthy Start program will provide doulas to women that meet certain criteria. March of Dimes provides doulas. March of Dimes doesn't support doula support for out-of-hospital birth, so there are, again, parameters and some limitations, but insurance itself, not so much yet.
Okay, great. And I'm just going to ask you this question. I know Dr. Giva, when she was giving her presentation, great one, by the way, she mentioned the gap between OB-GYNs and the primary care providers and how it's important to communicate with, to make sure the patient, at least information is going through both providers during the pregnancy. How do you communicate and keep in touch with the OB-GYNs during when you're taking care of your clients?
So funny thing, Dr. Giwa and I actually had a client/patient in common. We never met in person before today. But as a midwife, if that birthing mom is healthy, normal, no blatant risk factors, she doesn't necessarily need to see an OB. Midwives provide all of the prenatal care through the prenatal period, through birth, and through postpartum. However, we really do need more collaborative care. So if we have someone who has some elevated blood pressure readings, it's helpful to have a doctor who's willing to work with the midwife, collaborate care with that patient/client, and then if it stays as a high-risk pregnancy, then by all means, that birth should take place in a hospital setting. But oftentimes with diet, exercise, modifying a lifestyle, that mom can come back to midwifery care. So I keep saying the short answer, but just to stay in contact with doctors who are okay with midwifery care, I think is the first step.
Thank you. Collaboration, I think, is very key, collaborating with the community and other providers. Thank you so much. Dr. Giwa, what factors would you say are important when choosing a prenatal care provider or when considering hospital-based care and child delivery?
Is my mic on? Okay. Well, first, I want to say I'm so glad I met you. I've been sitting here thinking that she was the person that I've been talking to about my patient, but now I know. So that being said, I think it's really important. I think a lot of ladies look at a lot of things that are not important when they choose their doctor and they choose their hospital. And a lot of women are looking at aesthetics. A lot of women, and this is what patients tell me, they feel like, if the place is prettier, they're going to get better care. They feel like if the doctor sees private insured patients, the doctor is going to treat them better. And those things just aren't true. You need to find a person, when you're choosing a physician, first of all, choose them before you're pregnant. When you're getting your annual exams, when you're going for, whatever complaint that you have, birth control consultation, think, is this somebody I want to take care of me during my pregnancy? If they are not, switch. Make sure you feel comfortable discussing your concerns with that person. When you're choosing a hospital, make sure that the person that you've chosen delivers at that hospital that you want to deliver at. Some ladies they choose a doctor and they choose the hospital. They don't realize they're connected. So once you choose a provider, talk to your provider about what the hospital does. So I have a lot of patients who, for instance, have had a C-section and they want to deliver vaginally the next time. And so I tell them, these are the places that are going to do that for you. But in their mind, they want to deliver at X place. And so choose a doctor that you trust. So when that doctor gives you the information, you will take it. When they recommend the Tdap vaccine, you will believe that that's someone who is on your side. It's a team. So choose someone that you can be a team with.
Thank you so much. Ms. Matthews, how should women, and kind of along the same lines, how should women advocate for their maternal and child health outcomes?
I really honestly feel like in order to advocate, you have to be educated. So that's an effort we all play a part in. Where are they going to get the information from to advocate for themselves? So we all play a role in this bigger picture here, because even I think about the 12-year expansion of Medicaid, which, like Dr. Giwa say, it was showing up, it was constantly telling them this is something that is needed over and over again, and then we got it, right? So then what's next? It's always what's next. You fight this battle, but you also are fighting the battle behind it that says what's next. What's next is for folks to know now that you have a 1-year coverage, what it actually covers. So there's going to be a delay in everything that we are trying to get folks to understand until we look at education from a standpoint that everybody does not learn in the same way. For you, I may need pictures to go with those words. The next person may need a video. So when I think about advocating as someone who does it both on the state, local, and federal level, it's simply that. It's having the right tools to do it. And so any interaction or any information that we learn, I think it's up to us to start sharing those things out. So even in this room today, I'm pretty sure you're going to learn something that you didn't know before you walked through the door. So sharing that out, that's how we do it, because we can't advocate if we don't even know that there's something that we should be advocating for. And not being afraid to use your voice. If something is not right, say something. Because what lends to be the norm is because no one ever said anything. So if I was doing something wrong, how was I to know it was something wrong if no one ever had the courage to say, that's wrong, I don't like that? So having the courage to say when something doesn't feel good or doesn't feel right, just speaking up and saying something.
Absolutely. I was going to add to that, as a primary care provider, I always encourage patients to make sure you choose a provider that's going to answer your questions. I think that's one of the factors that you were implying, Dr. Giwa, that if you don't feel comfortable that a provider is there to listen to you, then perhaps that's not the best provider to take care of you during your pregnancy. Thank you so much, Ms. Matthews. Back to you, Dr. Giwa. What do you wish more women understood about their prenatal and postpartum care?
I kind of touched on this earlier, but I wish that women approached it like a partnership. When I trained, medicine kind of still is really patriarchal. And so the idea was you go to the doctor, they do the exam, they tell you what's wrong and give you medicine, give you the treatment. And really, we're moving away from that now, because as a physician, I only know what I know when I see you at the moment. You know what's happening every day when you're at home. You know your body. And so I wish that women approached it like that. Like, we're working as a team. I'm going to bring what I know, you bring what you know, and we're going to solve this together. I have so many patients that come and they'll know that they felt something wrong and they don't tell me. They're waiting on me to find it. Like, if she doesn't find it, then it's not wrong, and that's not true. So it's a partnership. And so choose someone that you can be a partner with and come with information. Don't expect the doctor to find everything. If you know something is wrong, you know you felt something, you know you have something, tell them so that they can process that with all the information that they have as well.
Thank you so much. Dr. Teriba, as a population health pharmacist, does chronic diseases, do they impact maternal and child health?
Thank you so much for the question. And Dr. Giwa is looking at me because she's like, I have said it. Yes, they do impact maternal health. And they impact mortality too. We all know mortality means death. That is just the basic meaning. When I received the invite for this program, I decided to look further into, okay, what is maternal health saying in the United States right now? And from there, I discovered about 6 out of 10 adults in the United States, they are living with chronic diseases. And out of 6, most of them, they are women. And this is increasing with advanced age, which is, as we are aging, this is increasing. What are these chronic diseases? Hypertension, Dr. Giwa mentioned it. High blood pressure, for those of us who don't know what hypertension is. Diabetes and cancer, they are the leading ones. Also, chronic diseases are the major underlying factor for maternal mortality. So what are the major ones? High blood pressure, cardiac issue. She mentioned cardiomyopathy, anything that has to do with the heart. And here we can see the roles chronic diseases play. I mentioned advanced age just now. Dr. Giwa said it. Women, we are delaying childbirth. Am I guilty as well? Yes, no, yes? I don't know. But because of education, because of survival, we are doing all this. All this, they contribute to chronic diseases. And we have seen it. It is affecting Black people a whole lot. Black mortality, Black maternal mortality is so high. She said it. If you feel something, if you see something, if you feel different, speak out. Talk to somebody. Talk to your PCP, talk to your OBGYN. Somebody will definitely listen to you. Also, how do we bridge this gap? Dr. Giwa, she works with the midwife. We call that multidisciplinary approach. Pharmacists are getting into maternal health right now. So they are there to review the medications, any drug-drug interaction, any drug-food interaction, anything that you are taking preconceptional stage before pregnancy that you should not take while being pregnant. Some blood pressure medications should not be taken while being pregnant. Then they can help to modify your medication. So you need to say something, speak out, so somebody can help. We have heard a lot. Dr. Giwa said everything. I keep mentioning Dr. Giwa. Hopefully I don't say that in my dreams tonight. But she actually said a lot. So chronic diseases, they do affect. Either you have pre-existing chronic disease or not, like preconceptional stage, conceptional stage, postpartum stage, they do affect. And let us keep advocating. Let us keep speaking up. If you feel something, say something. Speak up. Thank you.
Wonderful. Thank you so much. If you feel something, say something. And I certainly have learned a lot today. So one of my last questions here for the panel, and I'll start with you, Ms. Harris, is what is one way to improve birth outcomes for women and infants?
I think even as Ms. Matthews said, education is key. So we need education about what to do before we even get pregnant. We need to integrate care, as Dr. Teriba mentioned. It's not just solo care with a solo provider, but it's a big picture. And then we need to be willing to collaborate care. Many times just being very honest about it, midwives are seen as less than caregivers. But we have many wonderful outcomes, and often women just feeling heard and that they have the autonomy to birth the way they choose to birth. That takes away a lot of the stress, a lot of the headache. Racism is a risk factor, and when someone can choose a provider that looks like them, then oftentimes that helps. So we need a society that allows choices and then supports women to get the care that they need, and then that'll trickle down to the infants.
Awesome, thank you. Collaboration and representation. I'm going to ask you the same question, Dr. Giwa. What is one thing you would say that women can, what is one way you would say to improve birth outcomes for women and infants?
I'm just going to say Kay's answer again. I really think advocacy is so important, and a lot of ladies are coming to the appointments alone. They're coming to the deliveries alone, and that is difficult. It's difficult for me as a health provider because particularly when you're having, even if you're having a routine pregnancy, when I'm telling you arrive at the hospital at this time, go to this place, go to that place, sometimes you don't pick it all up, and you need someone there with you. When you're having complications, you need someone else to ask the doctor some questions, and not in a confrontational way, but just to say, okay, I think my sister forgot this question, you know, what is going on? I think a lot of times we've been saying advocacy, and sometimes, you know, people bring their family and they're like, we come to get you. And I'm like, I'm not the enemy. So, and not like that, but just so that we're all, that more than one person is hearing the information, that is so important. And I think it's a really big driver for health. So now I don't know what your answer is going to be because I took
You have to come up with a different answer. Same question, Ms. Matthews.
Well, I think it's a combination, really, of all of these things. Something just as simple as not taking away my choice. That's it. And if we are going to talk collaboration and collective, that still means don't take away my choice. Because sometimes collaboration and collective efforts can be one-sided, let's be honest. Like, I want this to be a partnership, but I want you to be the silent partner. So understanding when we say these things that we actually do these things, a lot of this is simple. It's not that we don't want to listen when we, like, women don't want to listen. I say we because I work in the community and I talk to these folks all the time. It's not that they don't want to listen and they don't want to do what's right, but they also want to be served with dignity and respect. So the moment you talk to me in any way that makes me feel uncomfortable or I'm disconnected. You disconnected, I'm disconnected. We ain't getting nothing. And so that comes back around to choice, respect, dignity, things like that. I feel like that is lending to our better, that will lead to better birthing outcomes. It's just like when you see the midwife, you don't feel some type of way. When you see the doula, you don't see her as someone who's trying to be the doctor. No doula wants to be a doctor. But that's how we see, or that the role of the OBGYN is to oust the midwife. So we have like this real, we have to change the way we view a lot of the healthcare systems and how we can really honestly, collectively work together. That's how we're going to make better birth outcomes happen.
Absolutely, thank you so much. And before I go back to Ms. Teriba with the same question, I do want to encourage the audience, if you do have questions, we'll be able to take them here in a couple of minutes. And Dr. Teriba, back to you. What is one way to improve birth outcomes with women and infants?
Thank you so much. I feel this is an opportunity to talk about what I do, population health and data analytics. So we can do that. This is not what you and I can do. This is what agencies, this is what the government, this is what organizations, what health organizations, Center for Disease Prevention and Control, these are the things they can do, like to incorporate the concepts of population health and data analytics. We have spoken about hypertension, which is high blood pressure, cardio issues being high in the Black community. What is the cause? Now we know that, okay, the population part of it is the Black community. What is the cause of this hypertension? Why is it high? Let us do data analytics. Should we throw out a survey? What are the ages? Do we want the increased age or Do we want people in their 20s that are just giving birth? What do we want to do about them? And that will take me back to what we have always known as a single influencing factor in the Black community, which is health equity, health disparity. That continues to live there. That continues to be there. Education is one of those things. Built-in environment is one of those things. Our neighborhood, what is there? What do we have access to? Healthcare facility, access to good healthcare, access to infrastructural facilities. So these are the things we can use data analysis to find out what we can improve. And Ms. Matthews spoke about something. You can take me out of somewhere, but you may not be able to take that thing out of me. So in an attempt to make me grow, don't let me forget my source. Don't let me forget my culture. Don't let me forget my belief. Don't let me forget my origin. How do we create a midpoint? How do we make it patient-centered? I am the issue, quote and unquote, here. So how do you make me feel comfortable to receive you and for me to know that you are not trying to put me down? So those are the ways that we can improve maternal health. Make people feel heard, collect the factors, collect the data, see what is happening, analyze them, be sincere with the analysis. And I think with this, we can have a way forward. And thanks to programs like this, thanks to the organizers, we are propagating the education, and it is going somewhere. People of color, we must be heard. Thank you.
Absolutely. Thank you so much for that. Definitely being heard. She mentioned being culturally competent. As the medical community, we have to do better, but we're being culturally competent and listening. And if I would add one thing as a primary care provider is addressing those issues. I always believe prevention is better than cure. There are modifiable risk factors and there are non-modifiable risk factors. I can't change your genes, but we can work on that, diet. We can work on exercise and things to reduce more the risk that we take on. At this time, I would like to go ahead and ask if there's anyone in the audience that has a question for any of our panelists, and we'll have someone go. There are two people over.
Hello. Okay. Hi, my name is Janae. I am a community health advocate, specifically for maternal mental health. So I have two questions. One question is, over 60% of Black women, over 80% of Black people in general go to social media for their healthcare questions, concerns, and problems. How are you guys as healthcare providers making sure that information is being spread on social media and that it is true and factual? Because a lot of mothers, they don't feel comfortable speaking up to their healthcare providers, so they go on social media to look for answers, and there's a gap between the amount of Black representation that there is on social media. So that is my first question.
That's an amazing question. And I am not on social media, I will tell you that. And I think, as you mentioned, it is a big gap, and particularly, well, I'm not going to say what my age is, but I think, if you didn't grow up with that kind of communication, it's a little bit difficult. I know at our organization, we will put out different videos on different topics to try to engage that population, but it's definitely not enough, and we're definitely not utilizing it as we should. So I'm glad you asked that question, so now I can start thinking about how to do that.
You're welcome. And my other question is, I think you kind of touched on it, how are OBGYNs making sure that beyond the mental health questionnaires that are given to mothers postpartum, how are you making sure that these mothers feel secure and safe, and that the next steps are being taken when they are addressing that, oh, I'm having postpartum psychosis, or I'm having postpartum depression, OCD, what steps are you taking? Because most mothers, like, okay, I told my OBGYN, but they are not therapists, so they don't know what to do, and now I'm suicidal. So that's my question.
That is a great question too. I guess I'm answering that question. But She did say obese. So the questionnaire is really the gateway for us. And I think that one of the reasons that I feel super comfortable as a safety net provider is because we have behavioral health on site. So when I practice, we are all trained to do the questionnaire. But when I was a solo practitioner, I was hesitant to do the questionnaire because when I got a positive, I didn't have anybody to send the patient, my patient to. And as a provider, that's scary. So now when our staff is trained, so when that questionnaire is positive, it pops up red in the chart. So I can make that referral to our behavioral health team. And I think one of the challenges is a lot of people don't want to, there's a stigma related to seeing a behavioral health specialist. So we have psychiatrists, we have social workers, and actually I send some of my patients to Kay. So I've called Kay multiple times and I said, hey, I have a patient who's experienced this and she doesn't want to see a therapist, so I'll send to Kay. And so that's what I've been doing, kind of expand the network for patients to have a support system when they are screening positive.
Okay, thank you.
May I address her first question as well? I think another way that we can reach those who are more so on social media, because again, like Dr. Giwa, that's not my strong suit, but some of us align ourselves with other organizations who have the same missions and goals. And so by being a part of these other organizations and groups, we're able to get our message in there a little bit. And then hopefully when young people like you who are very social media savvy reach out to those organizations and groups, you're finding those answers from the subject matter experts as well. So we're out there. It might not be our page specifically.
And we have room for one more question due to time constraints.
Hi, my name is Tan. I'm an internal employee here, but I'm asking this question for a educational purpose. So from a spouse perspective, what a spouse can do to provide the best support for a pregnant spouse?
I'll answer that because working in the whole entire family dynamic is our focus. We need everybody on board. When I talk about collective effort, I mean that. And so spouses, boyfriend, whatever the title is, that you need a support person. It's like what Dr. Giwa is saying, when folks show up by themselves, they tend to miss information. So involving a spouse, that's very important. That's something that we do, because in that postpartum period, which is primarily our focus, we see a lot of disconnect from everyone. The first child birthing experience is different. The fifth child, every birthing experience is going to be different, right? So maybe I didn't need any mental health support when I had my third child, but the fourth one took me through so much. I'm trying to gain my balance back, right? And so when we have a partner involved in that, they really could see that, because they'd be like, well, she didn't act like that with the second one, but that's a real valid thing to acknowledge. It's also a valid thing to know that that's valid, and that should warrant you then reaching out to someone. I have dads reach out to me all the time, which has prompted us to really build that into our program. I really have dads that be like, hey, we don't know what the hell to do. But that's a real valid feeling. At least they acknowledge that there is something happening that mom just may not see. That's another thing, that our partners see us before we see us. And so just knowing that there is support out there for partners, and getting them to understand that they are part of the equation, and that childbirth is not just on the mom or the birthing individual.
I'm fine. Okay, we're already over time. Thank you so much to our panelists. If we can give them a round of applause. Thank you so much. Ms. Harris, Dr. Teriba, Dr. Giwa, and Ms. Matthews.
Good afternoon, everyone. I'm happy to have you all. I'd like to introduce myself. I'm Virgil Elkins. I'm project manager here for the Community Engagement Corps, and I have the honor of introducing the next group of students here. I'm extremely proud of them. They have a rich legacy in the department. They've been around since 1970 under the direction of Dr. Thomas. If you visit their area, you'll notice that they have competed around the world and received merit awards and won various competitions. So I'm happy to announce the TSU debate team. If you would, give them a round of applause as they enter.
Each year in the United States, hundreds of Black women die during pregnancy or in the year after.
Thousands more have unexpected outcomes of labor and delivery with serious short or long-term health consequences.
Every pregnancy-related death is tragic, especially because more than 80% of pregnancy-related deaths in the U.S. are preventable.
Recognizing urgent maternal warning signs, providing timely treatment, and delivering respectful quality care can prevent many pregnancy-related deaths.
The Texas Southern University debate team is proud to present this Reader's Theater presentation, scripted especially for this occasion by head coach, Dr. Gloria Batiste-Roberts, entitled,
Everyone has a role to play in promoting Black maternal health.
Black women are 3 times more likely to die from a pregnancy-related cause, more cause than white women. Multiple factors contribute to these disparities, such as variation in quality, health care, underlying chronic conditions, structural racism, and implicit bias.
Social determinants of health prevent many people from racial and ethnic minority groups from having fair opportunities for economic, physical, and emotional health.
We must all work together to reduce Black maternal mortality. Learn how you can support pregnant people in your life to reduce factors that contribute to pregnancy-related complications and death.
Pregnant people and their families can talk to healthcare providers if anything doesn't feel right or is concerning.
Know and seek immediate care if experiencing any of the urgent maternal warning signs, including severe headache, extreme swelling of hands or face, trouble breathing, heavy vaginal bleeding or discharge, overwhelming tiredness, and more. These symptoms could indicate a potentially life-threatening complication.
Share recent pregnancy histories during each medical care visit for up to 1 year after delivery.
Connect with healthcare and social support systems before, during, and after pregnancy.
Healthcare providers can hear what patients are saying. Listening can be your most important tool.
Hear her concerns. It could save her life.
Healthcare providers should ask questions to better understand their patients and things that may be affecting their lives.
They help patients and those accompanying them understand the urgent maternal warning signs and when to seek medical attention right away.
Healthcare providers can help patients manage chronic conditions or conditions that may arise during pregnancy, like hypertension, diabetes, or depression.
Healthcare providers can recognize and work to eliminate unconscious bias in themselves and in their office on an ongoing basis.
They can respond to any concerns patients may have.
Healthcare providers can provide all patients with respectful quality care, irrespective of their race or ethnicity.
Hospitals and healthcare systems can identify and address unconscious bias in healthcare.
Hospitals and healthcare systems can identify and address social factors influencing maternal health, such as unstable housing, transportation access, food insecurity, substance use, violence, and racial and economic inequality.
Everyone has a role to play in promoting Black maternal health.
The Black Mamas Matter Alliance serves as a national voice and coordinating entity for stakeholders advancing maternal health, rights, and justice.
The Black Mamas Matter Alliance is a national network of organizations and leaders from a maternal health, human rights, and reproductive justice fields who believe that everyone deserves access to quality and holistic health care.
Black mamas have always been the guide and bridge for families, communities, movements, and waves of change.
The time is now to invest in this advancement in the movement of racial and birth justice.
The historical atrocities are deeply rooted in racial and reproductive oppression, bent on controlling Black liberation, and must be countered with community activation and prioritizing Black mamas across the African diaspora.
Everyone has a role to play in promoting Black maternal health.
Amita Parker shared a poem entitled Just Help Me, a research poem by Black mothers that tells the story of the maternal health and support experiences of Black mothers in the Midwestern metropolitan context.
Several excerpts from that poem include,
And when asked about my mental health, I replied, I had it until apparently I didn't. I was stressed at an all-time high, and I cried and I cried. I thought I was going to die.
Another mother said, pressure from every direction. It's a lot, all the time. Because of that, you just get tired of life, period. Just feeling heavy all the time.
Another mother said, when asked about supports for my mental health, there were things that came to mind. I have some things that are a root in my life, like the people in my life and God. They have supported me during tough times.
Everyone has a role to play in promoting Black maternal health. Another mother said, I need time, period. Just time to listen to music, time to cook, or time to lounging, whatever. That stuff is calming to me.
When my mental health is at a bad place, I'm really kind of vulnerable. Trying to deal with stuff on your own, that's a real headache too.
Everyone has a role to play in promoting Black maternal health.
If there is some type of support groups for Black moms, that would be so helpful. What about a mental health life coach? Is there such a thing? Someone that can guide me. You know what I'm saying? Maybe a talk line to call if you're feeling stressed. Someone who could be there for anyone, anytime or anywhere.
Everyone has a role to play in promoting Black maternal health.
Everyone has a role to play in promoting Black maternal health.
Everyone has a role to play in promoting Black maternal health.
Wow, what an amazing presentation. Thank you, thank you. Thank you very much, TSU debate team. You guys are amazing, and thank you to Dr. Gloria Batiste for, helping to coach and bring them on all the time. Wow, audience, I'm sure you guys have been intrigued with a lot of great and amazing information, from the speaker session. Thank you, Dr. Gewa, for sharing with us this afternoon. Thank you to the amazing panel. That was so beautiful. Thank you, audience, for staying engaged with us, even those that are online, sending in questions and staying engaged. We are going to move forward in today's programming, and I would like to bring up stage Dr. Lorna McNeil. One of the things Dr. Giwa mentioned was that intersectionality between maternal health and breast cancer. So this morning, or this afternoon rather, Dr. McNeil is going to talk to us a little bit about an initiative that is focused on breast cancer among Black women. Dr. McNeil is a tenured professor and the chair of the Department of Health Disparities Research. She is responsible for disparities research and community-based research initiative at the University of Texas MD Anderson Cancer Center. Our research focuses on understanding the influence of social context determinants of cancer in minorities, with a special focus on the role of physical activity as a key preventive behavior. Our research takes place in minority and underserved communities with excessive cancer death rate. She is the principal investigator of several community-based studies, primarily working with the African American churches, and she is the director of the MD Anderson Cancer Center for Community Engaged Translational Research. Dr. McNeil also served as the CCSG Associate Director for Health Disparities and Community Outreach, where she oversees MD Anderson's accrual of women and minorities to clinical trials, ensuring equitable participation among this group. Thank you, Dr. McNeil, for joining us.
Thank you so much. Thank you for this wonderful introduction. And I really thank you and applaud the efforts for connecting maternal and child health to breast health. And happy to talk to you about initiative which includes Texas Southern University, which is one of our strong and major backbone partners, of really trying to address the high rate of mortality among Black women around breast cancer in the greater Houston area. I'm going to provide data that tells you that we die at higher rates than other groups, something that we all know about. but really the death of George Floyd, the murder of George Floyd, as well as COVID-19 epidemic has really, I think, turned on the consciousness of a lot of this country and even in our community that says this higher rate of death has to stop. That we actually know what we can do collectively. There's resources available, great minds are available, activists and resources are available. What I think we haven't had before was a collective impact approach where we're all working together and not in our silos. So hope that you can support us in wanting to advance that among Black women in Houston. So even though breast cancer rates have been declining overall, not so true in Harris County, particularly for Black women who still have almost 3% higher rate of breast cancer. We present with later stage breast cancers that are harder to treat. And then we also have higher rates of triple negative breast cancer, things that you already probably know. And in 2019, 679 Black women were diagnosed with, 150 women of those died with breast cancer. We've been doing a lot for many, many years, but we can still do more. So we've come together with many organizations in the greater Houston area to form what we're calling the Texas Health Alliance for Breast Cancer. It's really focused on a multi-sector approach, bringing together hospital systems, community-based organizations, Black women, survivors, everyone to the table who is interested in order to align ourselves together. We recently received some generous funding from Bristol Myers Squibb Foundation, the Cullen Trust for Healthcare, as well as a grateful donor that is allowing us to pursue these three major aims. One is developing a shared vision together for what is it that is causing those higher death rates for Black women, and then what is that roadmap to get us there to solving that. We're going to use data that tells us where we should be going, who is most affected, what neighborhoods and places. And then the third aim is going to not wait for the data to tell us anything, but to implement what we know works now. And these are things that you've heard here today around navigation, partnering with community health workers as well as other organizations, focusing on social determinants of health, which you heard the great debate team talk about. These are things that we know work and that we have to do while we also pursue a data-driven approach as well. Our core leadership is listed here, and thank you for the active participation of Dr. Ajewole, Dr. Omanike, as well as all of the other groups listed here, University of Houston, Angel Surviving Cancer, and our UT Health partners, and of course, Harris Health, our safety net hospital provider system. Without these folks here, this work that we're gonna do is not gonna be able to be met. I say when everyone goes back to their day jobs and focus on other things, this group here is gonna continue to focus on this. And then there's a larger group of organizations that we welcome all of your active participation. If you're a survivor, if you're a Black woman, if you represent an advocacy group or a community-based organization and you want to join this coalition and join this team, we welcome you. There's an email address here if you can jot it down. Gil Matt Fuller is a project director at MD Anderson who is organizing this on our behalf. We look to see many of you wanting to join our meetings, learning how you can be involved and how you can do more and how we can save the lives of Black women in greater Houston area. Thank you.
Thank you. So at this time, let's see. We would like to see if you would like to complete a survey. Earlier on, we passed out some survey. We would love to hear from you. If you would like to have a survey, a paper survey, raise your hand. We'll have a helper to come and distribute it to you. If you have not, fill one out. So those who joined online, we also want to hear from you. So please click on the link and fill out that survey. It has been such a wonderful time together to listen to so much information, to hear about so much needs that we have, and also at the same time recognize that there is so much solution that we talk about. From community members, we have heard about all these different resources available in the community. So I'm just very thankful to have this time together, everyone, and to think about and to talk about this issue. So now next, we will get into the launch and overview of MH Reach. So you might, ask, what is MH Reach? So I kept going back to the last slide. So MH Reach is a Gulf Coast collaborative and Center for Maternal Health Research, Education, Advanced Training, Community Engagement, Health Equity, and Justice at Texas Southern University. And this is, I'm so thankful for our visionary research leader, Dr. Omoniki Olayeye. And it is her, you can come up, it is her that propelled a group of research team here at TSU to work nights and days and apply to, funding opportunity to all with one goal is to propel this effort to improve maternal child health. And so I'll have Dr. Omoniki Olayeye to say a few words and introduce our team.
Thank you so much. Let's give it up for Dr. Poon. She loves to give everybody else credit, but she's doing amazing, really helping train our early stage investigators. Who has the... Oh, you have it. Okay. Thank you. Okay. And I just want to correct Dr. Poon. It's not me, it is God. I have to acknowledge that. And just giving us this great opportunity at Texas Southern University to be able to do this great work with the great team I'm about to introduce to you and all the effort. I really appreciate what Dr. Poon and Dr. Ajole has been doing for our RCMI grant that they introduced earlier. A lot of that as birthdays and several other groups, like when we had the first meeting with our pastors' wives, and I believe, was that last year or 2 years ago, actually, we had our elected officials here, and they made a promise to me from DHHS, the federal government promised. I said, we're done just having and hosting meetings here. We need to stop talking and we need to move the needle in our communities. So let's give it up for God that made it happen. Come on now. We have to give the true credit where it is. And we're just handmaidens because not under our watch, Black mothers should not keep dying. Not under our watch. So thank you. I just want all those people whose picture is on there to stand up if you can. This is a great team. We work together. Some of us worked together for 2 solid years. Dr. Braley, I know I saw you, so stand up, please. Dr. Ajewale, Dr. Poon, Cecilia, come on now. Everybody, Dr. Gwen, I saw you all in the room. We worked really hard for 2 years with a national consortium, which I'm going to introduce to you shortly, meeting literally every Friday. How do we solve the issues with the poor maternal health outcomes in our community, the poor infant outcomes? How do we solve it? But also, we're thinking generationally, because it's going to take a lot to undo what has been done for generations and for years. And so we were able to work with a national team, and when this opportunity came forward with HRSA, this great team came together. Dr. Poon was right. I told Dr. Ajewale one time when we were trying to get a health mobile, I said, get out of maternity. We don't have time for that now. Come on now, write the proposal for and she did. So we're really blessed to have this great, talented team at Texas Southern University. We recently recruited Miss Cecilia Torres. She's actually helping us on the RCMI grant while we're waiting to hire our staff on this grant. Give it up for her, please, please. She put together that nice brochure that you have. She's also a epidemiologist. She was working on a Texas report for me. It got so big, I said, girl, we're going to make it a book. So thank you. And I'd like to give it up for Dr. Pounds, Dr. Gwen, and Dr. King. Please stand up, guys. Come on now. Dr. King looks so humble there. They just got a $50 million grant, okay? TSU is getting the attention of the federal government because we are truly integrated into our community, moving the needle. We're not just up here trying to be scholars, okay? We're done with that. We want our scholarly work to be translated into changing the real lives of people, not just looking at our publications, but how are we improving the healthcare, just like Dr. Giwa explained to us? How are we making that available in the churches, in the mosque, in all the places of faith, in our communities, reaching, touching every life. So these are the people. I'll also love to acknowledge Dr. Carla Braley. Dr. Sladden wasn't able to be with us here, but she's online. And again, Dr. Ajewale for leading the Research Infrastructure Core, as well as the two big projects. Dr. Braley is leading the Equity Project. She will share about how she's trying to build an equity model for our Black mothers. Like I said, not under our watch should Black mothers keep dying. We also have Dr. Ajewale leading the Research Infrastructure Core, and Dr. Braley and Dr. Slatton is a co-investigator and now co-PI along with Dr. Braley in building that model. Dr. Ajewale is also working on a novel medication therapy management plan, which I was so I shouldn't have been excited, but when I saw that cardiovascular events, is one of the top killers, and so knowing that TSU is deploying projects and people and students, give it up for our students in the audience. We have students, we have faculty, all working. These are just the leaders. There are other people that their pictures are not here making this happen. And of course, give it up again for Dr. Poon that takes her time. Give it up for her. Takes her time. These people are so humble, but they work night and day, literally. She holds the hands of our early stage investigators, our research investigators, our scientists, our students, our postdocs, our graduate students to write grants, to help them, teach them. How do you develop your research narrative? More importantly also is the fact that we were noticed globally. All the work we've been doing at the RCMI, the community engagement, all the work we've been doing globally, and the American Public Health Association decided that they felt like we're thought leaders, and they invited us to actually do a short documentary on all the work we've been doing on our health disparity work. And more recently, we were able to, with the other 3 schools that received this funding from HRSA in the state of Texas, and I will say TSU got the most money. Give it up for TSU now. We are not playing, and people know who can really do the work. Dr. McNeil just gave a talk now. When they received that grant from Bristol-Myers Squibb, when they put it in, they came and met with Dr. Ajewale and I and said, we know we can get this grant, but we know you all can do the work. So let's let you guys be one of our strong backbone partners. So TSU, we're not all about talking. We actually want to see the lives of our community improve. We want to improve all those economic issues that are underlying these things in maternal health. More recently, because of the article in Texas Tribune, guess what? CareSource came to pay us a visit. Dr. Giwa came along with them, and we were blessed with funding. Can you believe we started this new year with funding? Give it up for CareSource now. This is all the money we're going to use not only to do research and improve our community, but more importantly, we're going back all the way to K through 12. If we're going to change this narrative that is generational, I believe what I'm doing, I'm thinking about 1,000 generations, okay? When God blesses, he blesses to 1,000 generations. So we're going to go back to K through 12 and teach those little kids, what does it really mean to improve maternal health outcome? What are the disciplines? What can you study in college? You have to go to college. You have to go to graduate school. So that's what we're doing. We're going to be teaching little kids what we're working on. So that CareSource money, not only that, but the CareSource and the HRSA money will allow us to deploy community-based projects where you, the community, will be the principal investigator. Give it up for the community. You will tell us what the issues are. You will work in partnership with our early stage investigators, our faculty, to solve these problems. No longer will the scientists be the one telling us what the issue is, because guess what? We're stuck in the lab. We don't know what the issue is. But now we realize that we really need to have a real partnership with our community. I don't want to move on without acknowledging somebody very important in the room, Dr. Milton. She used to be our Dean Milton. She's a big supporter of our MCH programs. I used to write to Dr. Milton's fund my IDC so I can do some MCH work. I really appreciate your support. She's done a lot of great work with Match of Dimes. And I won't take your time. Investigators will tell you exactly about the project. Our goal really is to establish this strong center at Texas Southern University. Like what Dr. Giwa said, it doesn't make sense for us to be next to the largest medical center in the world. And Texas is having all those poor numbers when it comes to maternal health outcomes. It doesn't make sense for us to be next to the medical center, and Harris County has one of the worst numbers. So that narrative is going to change. by the grace of God with this great team. And also, like I said, we're going to be deploying at least 8 pilot projects with the CareSource funding. We're going to be able to do more. And remember, the lens by which we're looking at this, we're not just trying to do this and spend this money and get it done. No, we're thinking of systems. We're thinking of building infrastructure, for example, a CHW, community health worker infrastructure, that we can deploy community health workers into the community and get them integrated. We want to make sure whatever we're doing is scalable. To really move the needle, we need to do things that are scalable. We need to move the needle. Yes, one person at a time, but we need to scale this up in terms of building our capacity, building those that are going to actually do this work. And I love the idea from the panel as we're discussing the collaborative nature of healthcare. We really need to embrace that, and also making sure that the programs we're doing are sustainable. Because of time, I'm just showing you our paradigm. We go all the way from, like I said, educating not just the community, but also going back through K through 12. Our students here at TSU were one of the largest HBCUs in the country. So that is our population to really train the next generation of MCH pipeline. And this is just a group here that started all this narrative at TSU when it comes to the Maternal and Child Health Initiative. These are elected officials. What did I do? What happened? Okay. Yes, so basically we worked closely, like I said, with about 7 other HBCUs nationally. Dr. Bronner at Morgan State is the coordinating center leader. For 2 solid years, the 7 HBCUs, historically black colleges, worked together, meeting every Friday to make this happen. We worked with HRSA, and even though 16 universities are funded, 5 of our 7 HBCUs received funding for this work. Give it up for those HBCUs. These are some of our students. We received a HRSA grant about 5 years, and we were able to train over 125 Texas Southern University students. Come on now, Ego, stand up. That's one of our students. Stand up. Give it up for him. He's now a graduate student at UTMB. Okay, studying public health. He was a chemistry major, but we pulled students from our 10 schools and colleges, chemistry majors, engineering, music, and taught them MCH and deployed them into internships. And more importantly, they did research and produced real publications where they were first authors. And so we were really blessed to do this for our students to move the needle in the community. And we really hope to continue to be a part of what would really change these poor outcomes in maternal mortality and morbidity. And lastly, again, remember I said we're building systems. So part of the work we've been doing with our close partners like UTMB, Baylor College of Medicine, is really to deploy additional pilot projects, community-based projects, as well as research pilot projects to actually stimulate a lot of innovation in the area of maternal and child health. I'm really excited. It's the right time to be at TSU. It's the right time for you to partner with us, and we look forward to what's going to happen. We know we will move the needle by God's grace. Thank you so much. Thank you.
So next, I think we will have each one of the core to come up and talk about what they are planning to do. And so each one of us will have about 2 minutes to talk about it. Yes.
Good afternoon, and thank you, everyone. Thank you, Nikki, and all of my colleagues for this great opportunity. I am Kim Pounds, and I work alongside Dr. Gwynn and also Dr. King, who had to leave for another meeting. But I'm excited because we are leading the efforts of the Maternal Health Center in community engagement. So our primary goal is to ensure that the voices of the community are integrated in the work that we do and the decisions that we make. So there are basically 4 different ways that we're going to do that. One is through engagement. And in engagement, what we're going to do is, first, we're going to form a community advisory board. And that community advisory board is going to be made up of 10 individuals who have lived experiences in maternal health, and also organizations that serve individuals who have been impacted by maternal morbidity and mortality. Next, building capacity is important to us because here at TSU, we are growing and we are learning and developing new skills and knowledge around maternal health and how to address the issues that impact our community, but we want the community to grow with us as well. And so next year, we are going to offer opportunities for individuals to get community health worker certification, specifically around maternal health. So we're really excited about that opportunity. Dissemination is going to be important because that is our area's way of making sure that the community knows that we are using the information that we get from the community to inform what we do in the center. Evaluation, of course, is going to be important because as we learn and grow, we need to figure out what works for us as a center in partnering with the community to address maternal morbidity and mortality. So, if you want to get involved with our center, there are three in particular, ways that you can do this. One is through the Community Advisory Board, and again, we're looking for 10 individuals and organizations to serve on our Community Advisory Board. It's going to require a 2-year commitment. We will meet quarterly. Next, Community Scientist Program. We are bringing a Community Scientist Program to Texas Southern University, where people in the community are trained in how to work with researchers, and our researchers are also trained in how to work with the community. So they sit down together and they dialogue and share information. So then the researchers can get firsthand insight on how to create research that really truly will be impactful to the community, culturally relevant to the community, and understandable to the community. And of course, I've mentioned our community health worker training. And if none of these opportunities appeal to you or you don't have time, then please become a supporter of the Community Engagement Corps. We'd really love to have you listed in our database and be able to send you information on an ongoing basis. So I thank you for your time.
All right, so I am responsible for training and investigative development. And Dr. Olayeye had mentioned most of it, so I'm just going to cap it off. And so our goal is to build the next pipeline of workers who are interested in maternal child health, either as a clinicians or in research. So this is my overall role and scope and goal in the next couple of years to work on this project. There are two main activities that I will be engaged in, and one of them is to develop a maternal health disparity and research course, and that is to educate investigators and students about maternal child health, and also to develop a research training curriculum in MCH. So those are the main two goals, and this is the process on how it will be done. So we will develop a curriculum, and then it will be through a process where we will get some formative evaluation and evaluate the curriculum that we are trying to teach to the students. So if you are a student and if you are interested in learning about maternal child health, please contact me. My name is Ivy Poon, ivy.poon@tsu.edu. If you are a faculty member who teach courses that is related to maternal child health, please contact me, because I will be doing some assessment on what resources and education is currently available at TSU, and then we'll develop that curriculum and also the research mentorship so that we will build this pipeline of workforce for maternal child health research. And in the summertime, this summer, I'm very excited. Like Dr. Olayeye said, we will reach out to the K-12 community. So we are planning to host summer camps or summer seminar for students. So we will not only station at TSU, but we'll go out to the middle school, high school, and to motivate them that, hey, this is what you can do, and this is how you can be one day, develop your skills so that you can help and impact the community that they're interested to serve. So, so next, we have Dr. Ajawale.
Thank you very much, Dr. Pon. Thank you so much. Yes, so under the MH Reach project, I am responsible for the Research Infrastructure Core. And the Research Infrastructure Core basically provides support for all the amazing research work that some of us as the project leaders are going to be doing. You're going to hear shortly from Dr. Braley and Dr. Slayton about their equity project. I would also talk briefly about the project on medication therapy management. But not only is the Research Infrastructure Core supporting faculty-led project, we will also be supporting the community pilot project to make sure that the infrastructure is there to follow that concept of sustainability and scalability. So year 2 to year 5, we will be providing support to 8 projects, which will be 2 projects per year, and also leveraging the pre-existing infrastructure that we have currently at TSU. Dr. Lale mentioned, she touched on, some of these other programs, but all in all, we are going to be able to pull together a solid infrastructure that would continue to position us at TSU as we address the issue of maternal and child health disparity in our community. Again, we don't do it alone. I have the privilege to work with, community health workers that will be hired soon. We're going to have postdoctoral fellow, graduate research assistants, as well as working alongside our undergraduate students. Then I'm going to talk briefly, specifically about the project that I'll be leading under this initiative, looking at the concept of medication therapy management. Dr. Giwa was very right on point. If you look at that chart when she talked about the causes of morbidity in maternal population, you see that medication overdose is one of those leading causes in addition to cardiac events. So as a pharmacist, we review medications, we look at, okay, is there any drug interaction? Is this medication appropriate, even though you were taking it before you got pregnant? Should you and can you continue taking those medications? So it is really the same concept. Currently, as an oncology pharmacist, this is what I do for oncology patients on oral chemotherapy. I've been doing that from 2018 at Methodist Hospital, but we are basically going to adopt the same model and use that model for our maternal population. And in implementing this project specifically, we are going to first develop a work group of community individuals. Because when you look at the non-medical drivers of health, right, if you reflect back on one of the slides that Dr. Giwa shared, she talked about the social determinants of health, knowing that 20% is only accountable for access to health. But when you look at food insecurity, environment, transportation, all those factors. So we're going to have a work group that we're currently putting together, working alongside our consultant to be able to deploy that model so that we listen in to community members, to faith leaders, to mothers and physicians and OBGYN to be able to guide us as we develop interventions that we can deploy among African American mothers. The second part of this project is now for us to enroll 250 women. And when we do this enrollment, not only are we doing medication therapy management, we are also going to monitor their blood pressure, right? Blood pressure is about the most concrete number when you're looking at cardiac-related risk that we can track and monitor. I've been in conversation with Dr. Giwa, and she's already giving me pointers. Hey, let us do it beyond 12-month postpartum, right? So that way we ensure that we have coverage, not just during pregnancy, but even a little bit further beyond their pregnancy. So please, if you are interested in working with us on this initiative, feel free to contact me. Feel free to stay in touch with us so that way we want to make sure that we do this collaboratively. We are currently looking at creating the protocol, working with Legacy, working with Rainbow Health and so many of our partners, but we are in the planning stage and we definitely welcome your partnership and engagement. I will then turn it over now to Dr. Braley as she talks about the equity project. Over to you, Dr. Braley. Thank you.
Thank you. I feel like saying good morning, but I think it's definitely good afternoon. So I'm Carla Braley. I work hand in hand with Dr. Brittany Slatton, along with all the team. We help to co-lead, co-direct the Research Infrastructure Core, and we're the second project. I do want to just give a shout out because this project would not be if we have not gotten previous funding and through pilot work. That's through the Mears Center. Dr. Bullard continues to do great work in the mentorship of Dr. O, as well as Dr. Poon, who have both guided. We started off with doing the pilot project, Saving Black Mothers' Lives, and doing another pilot project with the University of Texas Medical Branch on Saving Black Mothers' Lives, basically life or death project. This led us to the Equity Project, Enhanced Quality, Universal, Inclusive, and Transformative Health Model to Improve Pregnancy Outcomes, the Equity Project for Black Mothers. I just want to say that what we're learning, and many of you all know that we cannot do this work in silos. And so Brittany and I, Dr. Slatton and I, come from a sociological background, which I think is a big additive in terms of trying to close this gap. And in this project, our first aim basically will be community-based, where we're taking a multidisciplinary approach guided by the life course theory as well as Black feminist thought to ensure that we're putting mother stories at the very center of our research. A lot of times we'll do this research and we'll talk around the mothers, but our goal is to make sure that we're listening to those stories that will be captured in digital formats, listening to the community to ensure that some of the strategies that they're able to do and inform and create awareness, that we're making sure that our research is guided by their strategies, along with focus groups and listening to local health practitioners in various studios. And then secondly, we're looking at creating this health equity model. Right now we have a community conceptualized model, also guided by literature, but our real aim is to make sure that we are taking all this material that we're getting, or data that we're getting, to develop an equity model that we feel will help Black mothers, but also if we can help Black mothers, we know we can have mothers in general. So that will be the goal, which will be based on evidence-based data. And then third, we're going to be having a training and policy component that will look at healthcare training programs, really eventually looking at impacting curricular, particularly in medical schools, and then hosting workshops and presentations that will be guided by the stories and data that we are able to collect. Then more importantly, is the policy recommendations. We can talk a lot about change, a lot about what needs to happen, but if we don't change policy, particularly like what is happening in the state of Texas, then we really remain at this stage for a very long time. And changing policy also connects directly with the type of funding that we can get. So that's more important as well. And then lastly, our aim 4 is disseminating research findings. You know, making sure that this research is disseminated. A lot of times, particularly in academia, we can conduct research, but it never goes to the community. And so our goal is to do all that we can. One of the things that we're primarily excited about is really attempting to create a health app. What we're finding that mothers are getting information from everywhere. I'm sure our health providers know that. Some of the things that we're actually showing in the research we're conducting is that mothers are even going to TikTok and finding those videos and people, influencers that are informing them about their health. And so we want to make sure that we're doing all that we can to stay on the cutting edge and to also have popular information, well, I should say information that is usually used to popularize things that are saving Black mothers' lives. And lastly, hoping that eventually the funding that we have will allow us to at least start working on a documentary to build on whatever else is out there. And I think that may be it, because well over 2 minutes.
Thank you, Dr. Braley. I was like, this was her health equity model as well. But For the sake of time, we will also be moving on to our last speaker, Dr. Valerie Garcia. She is a community transformation strategist for the National Healthy Start Association. Prior to joining, she held faculty appointments at NYU School of Medicine, Morehouse School of Medicine, Brooklyn College, and was selected as a JPB Environmental Health Fellow at Harvard University's T.H. Chan School of Public Health. Her work is focused on addressing the social, environmental, and structural determinants of health in underserved communities. Some of her past work has examined the sociocultural factors related to HIV risk among Black women, environmental barriers to healthy eating in NYC public housing, geographic and cultural factors to healthy sleep behavior, and the relationship between neighborhoods and cardiovascular health. Dr. Garcia completed her doctoral training in biobehavioral health for her PhD at Penn State University and holds degrees in psychology from Florida A&M University. Dr. Garcia.
Thank you. Good afternoon. So I just want to take a quick moment, and I know I'm the last speaker, so y'all like, come on, girl, just get on through it. But I want to say, so what the prior slide didn't share. So I am the granddaughter of 2 TSU graduates. As a matter of fact, their house is right at the edge of campus. And though I did not grow up in Houston, I spent all my summers right at the edge of campus. So TSU is dear to my heart. My grandfather passed 2 years ago, and he left to me his framed diploma, which reads Texas State University of Negroes. So he was a TSU student back then. And my grandmother was a nurse in Houston and helped deliver many Black babies around Houston. So this is a topic that's very important, near and dear to me. So I'm very honored to be here. I thank you all for having me, and thank you to Dr. Slatton for inviting me. So just quickly, what brought me here. As you can see, I've done a lot of work. I have a just keen interest in Black history. And so my interest growing up has been in psychology and how your mental health affects your physical health. So that developed into how being Black in America affects your health, like why we end up having such worse health outcomes. So a lot of my work across these different places has been about that. When I had my daughter, I had what they call a near miss. I almost died. Shortly after delivering her, she was born with a serious infection, and I almost lost my life because we were not listened to. My husband was with me. We told them this is what's going on. They were dismissive, and so we were in a very situation which was completely avoidable. So that on top of the fact that before I had my daughter, I had a number of friends who had near misses or lost their partners in childbirth. And so it was very apparent to me that this is a serious issue. So after having my daughter, I made a transition from academia to National Healthy Start Association, because similar to what Dr. Olayeye said, like we have the information, we know what to do, we need to get moving. It's very important to me to help encourage this new generation of scholars and researchers to get on board with this topic specifically. So HBCUs are near and dear to my heart, though I did not go to TSU. I went to FAMU and have worked in HBCUs. And so at this point, I sit as part of the National Advisory Committee for the HBCU Alliance, which you mentioned, led by Dr. Bronner at Morgan State, who helps to coordinate these efforts of the maternal health research centers at HBCUs across the country. So with that, let's see. I work for National Healthy Start Association, a part of the AIM-CCI team. So AIM-CCI, we have developed maternal safety bundles. These are a collection of evidence-based practices that we know improve maternal health outcomes for women. There are a group of safety bundles that are clinically focused. Ours is community focused, and that's what makes ours unique. And a major focus of our work is making those connections, as we talked about earlier today, between clinical and community. So it's not this kind of unspoken competition or headbutting, but really getting people to work together for a more holistic approach to maternal health care. So this is our team. These are some of our consultants. You're probably familiar with Dr. Fleta Mass-Jackson, who is the leader. We're just now starting to talk about, I shouldn't say we're starting to talk about, there's more attention being given to maternal mental health as it relates specifically to Black women and how racism is affecting our bodies and affecting our birthing. So this is a new thing in the common conversation, but Fleta Mass-Jackson, Dr. Jackson has been talking about this for years, so she's part of our consultant team. So I talked about what AIM-CCI is. Those are our bundles, our maternal safety bundles. And I'm talking fast because I want to get through it quickly and I want to get y'all to lunch. So the maternal safety bundles are available on our website. I don't have time to get into great depth about that today. These bundles are picked up by community collaboratives who, again, are working from a collective impact approach to bring together clinical and community partners. So we have a number of different resources on our website, which is aimcci.org. And what you can find there are information on the bundles. We have packages to help you kind of communities to pick up these bundles and start running with them. And then what is my baby, my second baby, is maternal monologues. So that's what I'm going to talk a little bit more about today. So maternal monologues came about because our program manager's sister was just like, I heard about these things that are going on in maternal health and Black women, and this happened to me like 40, 50 years ago, and I didn't know it was still an issue, and I want to talk with my church about it, but I want some context, or like, do you have any resources I can share, or how can I start this conversation? So we had this idea to create something called Maternal Monologues. And what it is, it's an online resource, and it's essentially a toolkit that anyone can pick up. You don't have to work for a university. You don't have to have medical degrees. You have to be a concerned community member. That's it. That's all the qualifications is for doing this. Let me just say, too, I'm going to say this earlier because I think it's important to state. The experience that I had with my daughter, I had a background in public health. We had a plan, a backup birth plan. We had all the things. I had a midwife. I had a doula. We were at a hospital. And still, we both had the outcomes that we had. And so our education, my education didn't protect me, but it shouldn't, right? I shouldn't get better health care because I have education and background and understanding, but I shouldn't get lesser care because I'm a Black woman. And my words and me knowing my body and what's going on, what I saw my husband saying, yo, this is what's happening, should not go ignored because you don't think that we know what we're talking about. So I just want to add that as well as an aside. But Maternal Monologues is, it's community stories of not just mothers, because we have a lot of birth stories out there, but it's stories from mothers, from partners, family members, birth workers, doulas, doctors, all about their experience of what they've seen in maternal health setting. And it's designed to tell the stories, but not to stop at the stories, because we see a lot of sharing the stories and the conversation ends there, right? So the next stop is to raise awareness by using these stories and then talking about, so what's next? We know what's happened. We see what's going on in the community. What are we going to do to address it? And so this toolkit is designed to start these community conversations. So this is the table of contents for the toolkit. There's like a quick and easy infographic that you can use to explain the state of maternal health. It's a boiled down version of like what we've done today. And then the maternal monologues are the sharing of those stories. And then there's a guide to creating them in your community. And there's a discussion guide. I'm gonna skip this slide and just kind of walk you through because it's here. So these are excerpts from the tool guide. And it gives you guidance on how to select your speakers. So imagine that you have sat here today and you want to do something about maternal health care in your community. That can be Houston, that can be your neighborhood, whatever the case, your church. And this walks you through step by step. How do you select your speakers? Who are the people that you want to share their monologues, their maternal monologues? Again, these are also fathers and partners, birth workers, clinicians, anyone who cares. And one thing that I felt it important to add to this is not all stories shared have to be traumatic stories. Those traumatic stories are important so that we know the gravity of what's happening, but it's important to also have at least one success story or one story of joy, because one thing we don't want to do is continue to talk about how terrible it is in the community. It is, but you can become downtrodden and feel like there's nothing that you can do, right? So to have an example of when things go right, what it can look like, the joy that's present, and especially I'm going to get into in a moment when we're using these in settings with young people, we're not in the business of scaring people out of having babies, right? We want you to have the information that you need, the tools that you need to kind of navigate that in a safer way. So how to select your speakers, how to support your speakers. Because to me, it's irresponsible to ask people to share such a personal thing and say thank you for your time and here's your parking validation, right? You have to check in with them and make sure that they're okay. So to be able to provide additional support that they may need, because for a lot of people this will be their first time publicly sharing their story, and they may not be able to anticipate how they're going to feel afterwards. So being sure to take care of your speakers, knowing who your audience is. There are a number of places that will be right for a maternal monologues type of program. University settings are perfect, and I'm going to talk about that more in just a second, but quickly. But also, as I said, churches, medical centers, and it may seem like, well, in a medical center, they already know about this. They do, but they don't. Because I think Dr. Ewa said she didn't get this type of training in medical school. It wasn't until she got into the work that she started hearing more about social determinants of health and all those other things that contribute to why Black mothers are having worse outcomes. And let me say this, I just want to be clear that medical racism is a thing, and we can talk a lot about making sure that women have prenatal care and that they speak up for themselves, but what's also important is what's happening on the other side, because you can speak up for yourself, but if you're dismissed, then you're still having this problem. And there are people who are well-meaning, who really are keen on taking care of folks, but when you work within a system that's been designed to ignore, and even there are protocols that don't explicitly say, but they are racist in the way that they advocate for you treating your patients, you may be doing harm unknowingly. So to have these conversations in medical establishments, medical practices and centers is very important to highlight this. I'm gonna move it on along. All right. So knowing your audience, figuring out where you want to do this. This is a discussion guide. So after you have someone share their stories, then the goal is to have a conversation. And these give questions to kind of help guide that discussion to bring the audience into it. And then where do you go from here? You are not going to solve the maternal health crisis in one maternal monologue setting. But what you can do is set some small goals. That goal can be to have people sign up, to be on a listserv, to have continued conversations. It can be to schedule another meeting to follow up to talk about what we want to do about it, right? So we had a maternal monologues event at Xavier University to kick off Black Maternal Health Week last year, and it was amazing, if I do say so myself. And I don't say that because I was a part of it, because really Xavier picked this up and ran with it. And these are just some pictures from the event. This woman here was an MPH student who shared her story. This is the audience. It was well attended. You'll see there in the background, there were tables in the background. There was a community resource fair. So after the stories were shared, after the conversations were had, there were tables in the background of maternal health related organizations that students could walk around and talk to get more information for themselves or to share with family members, to look into summer job opportunities, internships and things of that nature. Faculty members walked around with community organizations, and some collaborations are now in the works from that. So it has a lot of opportunity here. So this was just our program. I've already gone through that. These were the speakers. One of the speakers was a Xavier alum who is now a deputy director of the New Orleans Health Department. The medical director of the Louisiana Perinatal Quality Collaborative and Pregnancy Associated Mortality Review was there, and she gave us a beautiful kind of just quick landscape of what the maternal health situation looked like in New Orleans, because that's important, because we talk about the national numbers, but people want to know, what does it look like here? And sometimes that's what makes the biggest difference. And that was beautifully done today. So there were students, there was a whole panel of doulas, students, people involved in this work. Ms. Xavier closed out our program. She's also involved in maternal health work and gave a beautiful charge to the students that were in attendance. And these are pictures from the community resource fair at the back of the room. So from this, the students decided to start their own maternal child health ambassadors group. And so these are public health students, but they're outreaching now to students in other disciplines. And so their goals are to set up opportunities for mentorship, outreach, and advocacy around maternal child health issues, and to become more engaged in research. So I think this will just be kind of going back over what I said. The goal was to help people become more aware of it within the school setting, and then think about what they could do right there at home to move the needle on maternal child health. So this is a QR code. You can scan this with your phone, and it'll take you straight to the Maternal Monologues Toolkit. As I said, anybody can pick this up and run with it. If you have any questions about it, please feel free to email me directly. You'll see my profile is up on the website, but it's vgarcia@nationalhealthystart.org. I think that's, yeah, we don't have time for questions, I don't think. But that's it. There's my email address. And these are all of our resources. Thank you for your patience. I know I'm at the end. And thank you for this program. It's been absolutely beautiful. And I feel like it's hit on all the important things that sometimes get missed in these conversations. So I just want to, again, say kudos to TSU. It's a beautiful thing to be here and to be a part of this launch. And I'm excited for what's to come for you all.
Thank you very much, Dr. Garcia. Thank you, thank you, thank you. And thank you to the audience for being very patient with us. I see we are 30 minutes over the allotted time for this session, but I think this has been really incredible. We have learned a lot of amazing information has been shared. And I want to point your attention again to the survey. Your feedback is very important to us. Please scan the QR code that you see on the screen. The same QR code is on your booklet. If it's easier for you to scan it, please feel free to do that. It's right there on the booklet. And we really want to hear from you. For CHWs that would like to receive credit, go ahead and complete the credit request. The same link is going to generate from the QR code so that way we can issue your credits back to you. And I would like to give a few announcements on some of the upcoming events that we have at the CBMHR Community Engagement Core. We do have programs every month. Next month, we are going to focus on autoimmune disease, specifically looking at lupus. So please scan the QR code again so that you can pre-register to join us either in person or online. And then in March, we are going to focus on healthy aging, right? Aging is something that happens. We don't have, and Dr. Miss Lena, I see you right there. Yes. So we all age, but we want to age gracefully and we want to age in a healthy manner. So we're going to focus on Alzheimer's dementia in March. So again, scan the same QR code, free to pre-register. It's going to be available on Zoom as well as in person. One of the concepts I talked about earlier when I was, introducing Community Engagement Core was the need for us to move the needle forward in clinical research participation. So we are putting together another big conference about the same size as this, or even a little bit bigger, which is going to be on Saturday, April 20th, 2024. Hey, VP Clemens, thank you for joining us. Thank you. Good to see you. Thank you so much. So this is going to be Clinical Research and Engagement Conference, where we will bring people that have participated in clinical trials in the past, those that may be currently enrolled in clinical trials, PIs on clinical trials, to talk to us about their experience in clinical research. It's going to be in this same room on Saturday, by God's grace, April 20th. So please save the date, pre-register, and feel free to join us either in person or online. Artificial intelligence. Does that sound like a word that is all around the street now, right? Artificial intelligence is also another important concept that we want to make sure that we address and that we share empowering information about the role of artificial intelligence, technology, and health equity advancement. So this is Texas Southern University. We are taking the lead on so many initiatives. Save the date again. More information to come. June 2024, by God's grace, we are going to have our Artificial Intelligence Conference. Save the date so that you will be able to join us in person or online. How many people agree with me that this has been great? Who would like us to do this again next year? Yes, it will be bigger and better. By the grace of God, we will do this again. Friday, January 24th, 2025. So save the date, keep us on your radar. But between now and then, a lot of great information has been shared. If you remember when I came up, I said we're going to raise awareness, advocate, and I want every one of us to take an action that would help us to advance health equity in maternal child death. So between now and when we meet again next year on this topic, I want every one of us to do multiple things that would help us in advancing health equity in maternal child health. I want to take a moment to appreciate all our vendors, all our sponsors. Please help me to appreciate each and every of these organizations. Precinct 1. Jonathan at Precinct 1. Maybe he's outside. I know some of the seniors had to leave, but I appreciate them. They sent 4 buses from all the community centers at Precinct 1 to join us today, and we are really grateful. Thank you to, the Rose. They are currently out there on the Tiger Walk. Harris County Public Health, they have their mobile unit on the Tiger Walk providing screening at no cost, immunization at no cost to any and every individual that would love to participate in the programs. Again, this is the map. We have some vendors in the hallway, when you step out of this room, and several of the mobile units are out there. Once this session ends, we will be able to also serve lunch outside in the lobby. And again, I want to say a big thank you to all our support staff. Please help me to appreciate our staff members. Virgil, Sneha, Cassie, Nakisa, Ziomara, I don't want to miss anybody, Crystal. Every one of you, I truly, truly appreciate you. We could not have done this without you. And for all the departments that we collaborated with, facilities and event planning, Office of Marketing, AVP Clemons is here, Research and Innovation, Dr. Lale, AVP Penn Marshall, Department of Public Safety, they make sure that the mobile units got in safely and that everybody is safe. KTSU, they helped us to promote this event. And Constellation X, oh my goodness, thank you. You didn't turn off the mic on us. You guys are backstage, but I truly appreciate you. Thank you for all that you guys did in planning and implementing this event. And so again, thank you everybody for joining us. If you've not completed the survey, please feel free to do that. If you have the paper survey, we see Brett over there, please hand it over to her. If you have your paper survey, thank you again. Hang around and enjoy the resources from the vendors. Go to the Tiger Walk and participate in the no-cost health services that is provided by the Rose and by Harris County Public Health. Thank you for joining us today, and we look forward to seeing more of you. Thank you.
Hi, my name is Dr. Veronica Ajewale. I am the Director for the Community Engagement Core of the Center for Biomedical and Minority Health Research here at Texas Southern University. And we want to say a big thank you for joining us for today's program. We are sure that you have had a lot of great information that we are going to use together as a community as we work alongside each of us in advancing health equity. Please complete our survey, engage with our vendors, engage with our exhibitors, and do not forget to continue to follow us on all our social media handles. You can find us on social media pages at CECTX Southern U. We hope that you have an incredible time engaging with us for the rest of today's program, and we hope to see you at our upcoming events. Thank you for joining us, and we look forward to seeing you again.